So I won't talk too much. Thank you again. I'll just begin by introducing our first speaker, Dr. Rich Anderson. He comes from New York. He went to medical school at Johns Hopkins. From there, went over to New York, to Columbia to do residency, and he stayed there for quite a while. And then I think maybe just before the pandemic, around the pandemic, went to NYU, and he's been NYU pediatric neurosurgeon. His focus really is pediatric spine surgery, but the whole gamut of pediatric neurosurgery. But his passion is pediatric spine surgery, and it's really a pleasure to have you come here. And thank you, Mike. Thank you so much. Yeah, I think yes. I think everybody can hear, but the problem is the people on Zoom. That's why we have to make it hear. Just don't go too far. Thank you, Dr. It's a real pleasure to be invited here to the University of Chicago and to the Hackett Family Foundation Symposium. It's really a pleasure. When Eric invited me, I was very excited to come to Chicago for many reasons. But one of the reasons is to have an opportunity to share one of my favorite stories on Chicago. So coming from New York, I've always felt that Chicago and New York had a lot of similarities. And one of those nice things about it, sometimes you get to bump into some famous people. So the story goes, my roommate in college, his grandfather was a physician here in Chicago. Back in those days, he was a general practitioner. Back in those days, he was actually in house calls all the time. So it was mid-December, it was a cold night, snowing, and he got called by the concierge at a very famous hotel in Chicago to see if he would come down and see one of their guests who was having belly pain. So he shows his shirt, no problem. So he goes down there about an hour later, walks up to the concierge, and the concierge is like, "Oh, our guest is over there, and he's sitting in the chair across the line." So he looks over and he sees this gentleman. He's got this fur hat on, this long fur, long overcoat. The most interesting thing about it is he had this sable handle, just like this cylindrical. Turn on. Turn on. Yeah. Can you show me? Turn off the volume. Perfect. Is that better? Yeah. Oh, great. Thank you so much. So the most interesting thing about this man is that he had this cylindrical hand warmer. He's holding his hands in this warmer. It was made of sable. He's like, what kind of person would travel around with that?
just now, but it's required to turn the volume on here and back on. So,
Okay, great. I'll ask for you when we're ready. You're the best. Thanks, Jesse. Thanks, Jesse. So after asking that simple question of what type of bone graft should we use, then the next questions we started asking were, what are the consequences? We know we can do it now, but how does that affect the growing spine? Does it make a difference with instrument infuse a 3-year-old child versus a 15-year-old child? We know from scoliosis work from decades ago, you can't do or instrumentation, in a 5-year-old child, because then their lungs aren't going to be able to grow, and they grow up to be, adults with 5-year-old lungs, and they end up dying of pulmonary death. You just can't do that. So no one ever looked to see no one's ever studied, well, how does it affect the growing spine? So one of the first things we did was we wanted to look at these common procedures. And we took patients after C1, C2 fusions and after O2 fusions. And what we learned was that after C1, 2 fusion, there's near normal growth of the cervical spine, even when you do that short segment fusion. And so that's probably the reason, because it's a short segment and only fusing one level. And in the majority of patients, even after an O2 fusion, you still get some growth. We learned that after almost 5 years of follow-up in patients that underwent C1, C2 fusions, an average of 31% of the vertical growth of the cervical spine occurred within the construct of C1, C2. And we didn't see, at least in that early follow-up at about 5 years, we didn't see a lot of adjacent segment disease or abnormal crankshaft or things like that. And it's probably because we get remodeling. When you put a screw into the leg of a kid in the femur, there's bony remodeling around it. And the same thing happens in the cervical spine. For O to 2, about 80% have some growth, but it's much more variable. And about 20% have no growth at all, for reasons that we have granular enough data to figure that out. But very few developed, hyperlordosis or unintended fusion or things like that. So this was a good start. But you'll notice that when I talked about that, I said it's a certain percent. Like there was normal growth, there was 80% of normal growth, but I didn't tell you what that was in comparison to what normal should be. And that's because when we were doing this study, I was very frustrated because nobody knew what normal anatomical growth of the pediatric cervical spine was. Okay, we knew that it from Dak and Payne's work that it reached more biomechanical maturity about 8 or 9 years of age, but nobody knew what the normal anatomical growth of the cervical spine or when it stopped growing. So I leaned on Cormac Mahler, one of my buddies out at Michigan, who's now at Stanford, because Michigan has this huge database, radiographic database of CT scans. And so we did a cross-sectional analysis to look at that. And what we found is that, in terms of the cervical spine, about 25% of anatomical growth in a child is at the craniovertebral junction and about 75% in the subaxial spine. But it's different in boys and girls. We learned that basically around 13 years of age in young girls, the cervical spine stops growing anatomically, and in young boys it stops growing around 15 years of age. But the interesting thing here is that biomechanically, the cervical spine reaches more like an adult at around about 9 years of age, but anatomically, it doesn't reach maturity until about 13 to 15 years of age. So then we wanted to do a similar study of looking at the subaxial spine. Okay, so what if we use these kids 2, 3, 4 level constructs in subaxial spine? How does that affect growth? And what we found is that when you do the type of surgery in subaxial spine, you get growth in about 2/3, and you get growth at about somewhere between 80 to 100% of what is expected based on normal growth, based on the studies we talked about. And again, new deformities or unintended fusions are really rare. So these are 2-level, 3-level, and 4-level fusions in subaxial spine, and the red line is normal growth. And then the patients are in the blue lines. You can see when you have a 2-level fusion and a 3-level fusion, the slope of that line is very similar. So the growth in those patients is essentially normal. But when you get to 4-level fusions, the slope of that line really drops off, which is telling us that when you're doing multiple level fusions, then that's affecting the overall growth of the spine. doesn't really affect the diameter of the spinal canal because the diameter of the spinal canal, like room for the cord, is fully mature by around 3 or 4 years of age. That's much. So the next thing we wanted to look at in terms of growth was simple cervical thoracic. So these are really rare and these are really tough procedures. Okay. Louise has a bunch of experience with this at Cedars-Sinai, and these are kids. This is a kid with skeletal dysplasia who basically came to see me about 3 months of age. He's got a terrible kyphotic deformity in the neck. And these patients really almost like stall as long as possible because the options to put in rigid cementation are really low. But about 1.5 years of age, he starts developing myelopathy and cord compression and signal change. So I had to do something. But the bones are too small here to really put any type of adult instrumentation in. So sometimes the only option you have is to do these long constructs because you can fix in the occiput right in the keel, and you can fix in the thoracic spine by putting pedicle screws down there. And then you do this long construct. And this kid did great. You know, nice construct. He's got great fusion. And this kid's 70 years now, something that's done beautifully. But it doesn't always work that way. Here's a kid with Lewis-Dietz syndrome, a connective tissue disorder, another rare disorder, another kyphotic deformity. So I'm like, okay, well, this child was only 2 years of age, so similar limited options. So we're going to do the same thing. And when you go from here to here for initial postoperative X-ray, my residents, we're high-fiving each other. That's a great X-ray. That's a whole lot. I'm really happy with that outcome. But then when it comes back 1 year later, this is what it actually looks like. Let's zoom in on that. You see here C2 and then C3 is here. So there's been a complete, dislocation here. And it was interesting. I could talk to you later about why I think that happened. But this isn't a long-term solution, and this is going to need fixing at some point. Fortunately, the kid's still fine, no swelling issues or anything like that. So we're stalling because he's got a nice fusion in the back. But we have to do better with this because when you put together this collaborative study with about 13 patients, this was a little while ago. And this was kind of the first time something like this has been published before. I went back recently and I talked to all these authors for these patients, and over half of these patients that have had these type of procedures have had to go back for extensive revisions, extensive problems, and big time difficulties revising conscious. So we've got to do better with patients like this. And these are a lot of the kids that we're talking about in this audience. So we've come up with some, I think, baby steps. So this is another kid that came in with a virtual complete spinal dislocation. This one we had to go from the front and the back and so forth. But again, you've got to do a long construct here because lateral mass screws a couple levels above this are not going to hold a 3-level vertebral column resection. Spine just it'll fall apart on you. So you have to do this. But I looked at this and went, look, there's nothing intrinsically wrong with the craniovertebral junction. What's intrinsically wrong is right here. So what if we instrument there to get this to fuse and then take them back and disconnect the occiput? Don't lay down bone back at the occiput, disconnect that. You might think, oh, Anderson, are you kidding me? What's the point of taking it back where you're only taking out this much metal? What's the point of that, right? But what you got to remember is that biomechanically, it's based on adults. 40% of the motion of the cervical spine is the craniovertebral junction. 0.1 and 1.2. So when you disconnect here, you can restore about 40% of the motion there. So it can be a meaningful difference. Not always, but it can be. But I work daily with your orthopedic surgeons a lot, and they use rolling constructs all the time in the thoracic spine. I mentioned that you can't do a scoliosis surgery and fuse these kids in the thoracic spine because of their lungs. And so they have rolling constructs, whether it used to be, Vector and so forth, now Magic and so forth, where you can magnetically lengthen the rod to try to provide some growth as they grow and get their lungs bigger before they have to go to definitive fusion. But these constructs are way too big for the pediatric cervical spine. So what I thought at this time is maybe if we could do some type of Schiller construct. So for those of you who aren't familiar with that, Schiller construct, most of the time when you're putting in screws and rods, you lock you put the screw in, which is a saddle in your rod, lock the cap down to keep everything totally rigid. In a Schiller construct, the cap is not locked to the rod, so it allows the rod to slide. Okay, and so the concept is you've got a kid like one of those that I showed who's very young, and maybe you can lock in the occiput, some screws in the rest of the spine, use a Schiller system, and leave the rod long so the kid can actually grow and have some growth there. So I haven't done this yet. I've got a kid coming up that's going to need it, but we need to do better. The bottom line is we need to do better than we do. So I think the one of the next things we're going to look at is we now know we can do it. We've done some studies looking at, okay, how does it affect children when we do it this way in terms of growth? I think we need to understand better when we have to do it and when we may not have to do it. So the indications, and when we look at indications for stabilization of the cranial-vertebral junction, trauma is much better understood. Again, to a large degree from Dr. McPain's work and others. With C1, C2 rotatory subluxation, he's done some really elegant work with that in terms of if it's a chronic problem, you essentially have to operate. If it's not chronic, you can fix it early, and you don't need surgery, trauma and so forth. But with the kind of patients that with congenital syndromes and rare things, it's much more difficult to delineate exactly what we need to do. Doug Brockmeyer's done some great work looking at complex Chiari. So when these children with these complex Chiari situations come in with some vasodilation and other things, trying to put together a combination of radiographic parameters like the CXA or the PBC2 in combination with clinical symptoms, what type of clinical symptoms they're having, and under which situations is it more likely to be a fusion versus we're going to be okay, and these kids are going to, the majority of these are going to be fine by just doing a decompression as opposed to putting them through a more extensive operation like a fusion. But what I'd really like to get to is we have something called the ETV success score, which is the endoscopic tracheostomy success score. What it does is that if you look at the child's age, hydrocephalus, look at the child's age and etiology, whether they've been shunt in the past, you can predict with very good accuracy whether this procedure is going to be successful for this child with hydrocephalus. There's been a lot of great work from the Hydrocephalus Research Consortium to put this together. But what I would like to do is develop a risk factors for CV junction instability score. And you put in age, you may put in their genetic diagnosis, you put in some radiographic parameters, you put in clinical factors to tell us, to try to figure out, okay, this kid is going to end up developing a progressive kyphosis. This kid needs surgery. This kid needs stabilization. Whereas this other kid, look, this kid has Down syndrome. He's got some, excessive motion, but this kid doesn't. This is what a big project that we're starting to work on. So where should we go? We need to increase our understanding of the biomechanics. I talked about developing a scoring system, but why is it that all these kids, we're biomechanically, we're putting the weight of the entire skull and brain on one motion cell. All the biomechanical forces of this are basically coming to this one C2 3-disc space right here. But I can't remember the last time I saw a kid come in with adjacent segment disease at that level requiring extension down into the subaxial spine. Maybe it's because we've only been doing this for 15 years this way, and maybe it's 40-year follow-up. I don't know the answer. Maybe there's something different about what we do when it's wrong. I don't know the answer, but there's something biomechanically going on there because in adults it's much, much different. So, just to spend the last couple minutes here, I want to focus on how we're going to get there. And the way we're going to get there is with recruitment and collaboration. For, if there are any residents here or listening to this online, if there's one thing I want you to remember from this talk, one thing alone, is that the days of single center studies are over. Okay? Nobody cares how 50 patients with OC fusions done by Rich Anderson do 10 years ago. Nobody cares about that. People care about how 500 children with OC fusions do from across the world 10 years later. Okay, and we don't do it enough because it's really hard to do it. Okay? So, my entire career has been doing these types of studies, and the way that works is that I come up with an idea, talk to my buddies about it who do this type of work. I get buy-in from them. I write an IRB. I get it through my institution. I include all their institutions as collaborating institutions. I send it to those institutions. They've got to get their local IRB on board. Once that all happens, then you've got to get individual data use agreements for each of those institutions. That goes through all the lawyers and all that kind of stuff. And then we actually collect data. And then we collect data. It's all de-identified. It's like the simplest data you can do. No HIPAA rules or anything like that. You collect the data, you do the analysis, you write the paper, it gets published. That process, on average, is 3 years. 3 years to do that. Okay, that's why we don't do it, because it takes too much long. It's 3 years and at least 300 emails, phone calls, and texts. All right, it's a broken system. It shouldn't take that long. The solution is registries. Okay, that's the only way we are ever going to be able to get to a better understanding of these rare disorders that people see times. So we started this project, and I realized that we had our group in pediatric neurosurgeons, the Pediatric Cranial Surgery Society. We started a red cap database to do exactly this. But then I found out that the orthopedic surgeons, who do a few of them who do cervical spine work, were doing the same thing. And then we find out from our colleagues in India, they're doing the same thing. So we got 3 different registries working together. I'm like, this is ridiculous. So what's the solution? After a couple of years of this, what became clear, the solution is the Pediatric Spine Foundation. This is an amazing organization. The single purpose of this organization is to focus on studying the growing spine. All right, it has over 180 members, 80 different institutions from all over the world. We've got 11 different countries. We've got, obviously the majority are in North America. We've got Europe, Asia, Africa, even down to New Zealand. And this is growing. This is growing because it was initially started by the orthopedic surgeons, but they recognized that in order to get to really be the end all be all and understand the growing spine, they needed neurosurgeons involved. And the database is over 11,000 unique patients. It's the largest spine database in the world. It's collaborative ortho and neuro. It's international, has a $1.5 million budget annually. And we've done multiple studies on this already. We looked at initial studies about, okay, if you detether a spinal cord, how does that influence the progression of scoliosis? Is it safe to detether a spinal cord and do intradural work at the same time as putting in some instrumentation for growing constructs for scoliosis? The way that it's done is through research interest groups. When you join the organization, you can choose which research interest group you're interested in. So there's a cervical spine, and what's really, really exciting is that we're just now starting called the neurogenic rig. But I wanted to get back to that asterisk because there's that big hole in OC fusion. So that's one of the first studies we did in the cervical spine rig. So we looked at children less than 21 years of age that underwent simple C2 fusion with 2 years of clinical and radiographic follow-up. And we defined fusion failures if they had revisioning after greater than 30 days to exclude like infection, stuff like that, or if there's hardware failure or screw haloing. And we did a multivariate analysis. And interestingly, in this study, 75% of patients were patients that are very germane to this audience. Syndromes, congenital malformations. 75% of patients in this study had things like that going on. This isn't even published yet, but I'll give you a quick preview. The failure rate was almost 40%, much higher than what's been reported in literature. And I think the reason for that is because most studies just look at if you have to go back to the operating room or there's a screw breakage, that would be failure. But if we had screw haloing, then we took that as to be a failure because at some point if there's haloing, it's a pseudoarthrosis. And we can't do CT scans on these kids for radiation exposure. No one's willing to do that. And when we looked at a multivariate regression analysis, the only factor that influenced failure versus non-failure was if you use structural rib autograft. And if you use structural rib autograft, when you do these, if you take their own rib and use it for the fusion, 75% less likely they're going to have a fusion failure. This changed my practice already. It has been published. I saw the data. Changed my practice already. So this neurogenic rig, I recognize that I love pediatric spine, but not every pediatric neurosurgeon loves pediatric spine. But one thing that we've convinced the orthopedic surgeons and the board of this foundation is that if you want to understand the growing spine, There are intradural processes that have tremendous influence on the spine. And every pediatric neurosurgeon takes care of kids with tennis spines or CX or or intramedullary spinal cord tumors. And so what we've convinced them is we're developing this new rig or this new part of the registry so that every pediatric neurosurgeon who takes care of tethered spinal cords can put their data into this registry so we can start asking questions about tethered spinal cords too, when you have to do it, when you don't have to, risk factors, complications, all that stuff. So I think this is a tremendous opportunity for us to get many more pediatric neurosurgeons involved in a registry based thing for tethered spinal cords. So what would the Guardians have to say? Oh. Where's Jesse? Jesse, I need you. What do I do? They got to hear this. Thank you. Thanks, Jesse. So back to the Guardians. I figured we would. Turn off. Good. No. Yeah. It's fun. Let's turn it up.
We're the Guardians of the Galaxy.
So I think the Guardians would say that the only way we're going to get there is by working together. That's all I have for you. Thank you. Very good.
Anyone hear me? Thanks very much. That's really nice. Let's see any questions you have for Eric.
No, so excellent talk, Rich.
I would think so.
Okay. So excellent talk. I think I totally agree with you about the collaborative, working together for these for any sort of study, especially in neurosurgery, especially in pediatric neurosurgery, where it's a relatively very small field. And I think the days of the single surgeon, single site, retrospective publications are hopefully fading away, because as we've seen, a lot of those results are impossible to replicate, whether it's because they're amazing technical surgeons that no one can actually replicate, or they have amazing selection, or they have amazing selectivity on who they actually include in studies or what. So I just want to totally echo that thought. That's not.
Yeah. Any other questions? You want me to? Yeah. I'll do it.
All right, sure. You're right. Okay. So I think so this is exactly what I do, and I've heard of thanks to the Pediatric Spine Foundation and all these interest groups. I think the thing that I struggle with is a couple things: the natural history of skeletal dysplasia, which kids are at risk. What kind of follow-up do I need? Do I need to see some kids more often? am I ordering the appropriate studies? I think most of us are getting standing films, EOS films on these kids, looking at balance as opposed to just in a focused C-spine film, which may not show that. And so, I like the idea of having sort of a score for risk of needing spine surgery in the future. I think the the other correlate is some sort of guideline for the rest of the community in the world. If this is something that's very rare, I think having guidance for people that are not seeing this all the time would be so very helpful to at least identify these kids at risk for having catastrophic spinal cord. So I think that's great. I think it'll be complex, possibly.
It's a long-term project. Steve, you've got such a great, first of all, we're so excited to have you at PSG. You're such a great leader in that. You've got such a great perspective because of your experience and leadership with guidelines from the CMS Foundation and so forth. I think that, as you point out, that project looking at risk factors, it's going to be, it's a 10 to 15 year project. The problem is the only way really to get there is to get people to enter non-operative patients into a registry. And it's a heavy enough lift getting people to enter operative patients into a registry, much less non-operative. So it's the only way it's ever going to happen is from buy-in from. So we'll keep working.
The idea of kind of having an individual institution. I mean, that's really what the Hackett program. I think probably it was David's idea, originally that brought the consortium members together, because not necessarily spinal fusion, but these rare diseases that you can't get in one institution enough information to be able to make a meaningful study. I think, and the same thing. I mean, it's taken 3 years for the IRBs to get approved, and every institution has different speed. The IRBs it's taken multiple years to get these approved, to get to the point where we can finally do some studies. It's certainly rare.
Yeah, it's a great point. I didn't mention though, but the beauty of the registry is that there's a universal IRB. So once your institution signs on to the IRB for the registry, then you come up with an idea, you go to the registry, you pull the data, and you have data within 3 months. There's no extra data use agreement. There's no extra IRB. It has shortened the time for us to go from inception of idea to publication. It's cut in half.
I think it's fantastic, obviously. A lot of common interests and common friends. And
Yes.
your training includes that. But one of the biggest challenges is going to be, you alluded at it, but for the audience, is that looking at first adult spine and then looking at normal versus skeletal dysplasia and congenital spine is completely different. In fact, trying to judge when to do surgery based on criteria that has to do with non-skeletal dysplasia and developmental spine will be different, and we don't even know what the measurements are in most of these diseases. And it goes back to, Julie's here, she kind of tested that when we look at kids with achondroplasia and head size and hydrocephalus, those original normograms are based on 40 patients or something like that. Dave Vermoyen kind of sat down, pulled out 40 kids and drew all those. There were no MRI scans, no one knew what matricular size was because imaging was not available, and built those. And that goes for all of the cervical spine as well. And the measurements and what's normal for a kid with skeletal dysplasia is not going to be the same as a kid with traumatic subluxation, et cetera. And all those have to be worked out. And the only way it's going to be worked out is things like the Hackett Consortium or your cervical spine group, et cetera. And part of that is going to be getting geneticists involved, because you said non-operative patients. We see a small fraction, and then we decide not to operate on a certain number. The true number and really getting normograms is really not us. It's the geneticist and the first people.
That's a great point.
I had a question. we've got a few residents ducking their heads in the back there, but I mean, this is very highly technical surgery. And one, it's highly technical, and two, you don't need that many necessarily surgeons to do, the training. So for a resident, I mean, you finish your residency and then, how long would it take to become, to like master, to do these kind of things, where you're dealing with a child who's say 2 years old, but also an adolescent who's, 15 years old, and there's major differences in that. So
Yeah,
thoughts.
it's a great question. I'm sure I have a very good answer for you, because the techniques that you're going to use the same. Placing the screws, placing a translaminar screw or a transdural screw. It's the same techniques that you're going to use even in a 2-year-old as an adult. It's the comment I would make is that from colleagues that mine, and when back in the days when residents doing adult surgery, you come up with an idea like, okay, this patient needs surgery, we're going to do a fusion from this level to this level, but it's standard, you're going to put in pedicle screws if you're doing a posterior approach, and it doesn't really matter what instrumentation company you have, they're going to have what you need, they're going to have a cage, they're going to have this, whatever. But with a 2-year-old child, you have to know exactly what size screw before you get into the operating room. You may need a screw size that the instrumentation company is not going to have. And you have to special order to make a smaller screw, an 8mm screw, instead of 12mm screw, which is what they standardly carry. So you've got to look at the anatomy on your CT scans, and you've got to know, okay, is it technically possible to put a 3.5mm diameter screw up the pars of this child, or do they have a pair of verts, do they have this or that or whatever, or a congenital anomaly that doesn't permit that because the pars is only 2mm wide. You're going to have really a tough day if you go into the operating room, start trying to put a 3.5mm screw down pars that's only 2mm wide. It's going to make for a bad day. So that's probably the caveat. It's just the kind of the way of thinking about it is there's a little bit extra, I think, when you're taking young children. I'd be interested to see what Maurice and Dave, what you guys would say about that. Any comments about that kind of stuff?
Wait, you're thinking about what's the path to doing this type of work?
Yeah, exactly. That kind of thing, and then also, it's how long should somebody be considering? I mean, it's like becoming a master, like vascular surgeon. It's a really highly technical surgery, and you can't just come out of a spine fellowship or pediatric fellowship.
Yeah, the good thing is there are more and more pediatric. So in the past, most pediatric neurosurgical fellowships didn't really have any spine training, but now more and more fellowships, David's fellowship at Sinai, and there are more institutions now where, as a pediatric neurosurgical fellow, you're going to have much more exposure to spine. And the good thing is that now, even though this talk was only about cervical spine, most of us do a lot of work in the thoracolumbar spine now, and so more fellowships are providing opportunities for training in that as well.
I can give a little insight into that, and I think this is important to think about. How can you be safe, doing this type of work? And it's not just coming through residency and fellowship. I spent just my personal story, many years working with senior spine surgeons to develop my skills and doing co-surgery. I think that's the way to go at many centers. I still do many cases with other experienced spine surgeons just because of the technical factors. We want patients to do well, to be safe, and no one's sort of on an island. And so to me, that's it's collaboration, and it's just an experience, and having an interest in caring and wanting to take care of patients that have very difficult problems. And so I think that's the thing. A lot of us go through training. They go, we're fully trained, and we're and still everyone learns. And so it's all about lifelong learning. So sorry, Mike.
Yeah. When you're a fellow, you think you're fully trained.
Yeah.
So it's really interesting. It kind of mirrors what's actually happened. So when I joined the LPA, there were no pediatric neurosurgeons involved in that type of work or coming to the LPA. And it was really working with a pediatric orthopedic spine surgeon, deformity surgeon who was very experienced in this. And both of us learning from each other. In fact, probably were the first group that the neurosurgeon actually worked with an orthopedic surgeon, such a, everyone to their side and duke it out kind of a thing. And, personally, for the residents, I did a inter-residency spine fellowship with Steve Andra. So that was kind of like in the old days where pedicle screws were just beginning to be used. These are people who actually designed the pedicle screws, and things have progressed quite a lot. And every day I learn. And Matt's now at the Shrine, so he's left, and Alex Tuchman, our adult spine deforming person, is now taking over and working with skeletal dysplasia. And every day I look over and I learn from his deformity stuff, what else is going on, and think actively. So if you're going to do pediatric deformity in spine, it is partly pediatric neurosurgery, partly spine fellowship, partly working with an orthopedic guy to learn from him and him to learn from you. And it's a very new field. This is not established. This is not, okay, you do this fellowship and it's done. Our residents learn, then they do their spine fellowship, and then the path to learning and really understanding what to do. And the basics of it is learn the mechanics of it, try to understand how that applies to this congenital spine. So like you said, I spent hours looking at the MRI scan, and Alex and I look at everything together and think of all the connotations and what we know and try to figure it out.
The tough thing is that there are a few centers where that culture is well established, and there are other centers where that culture doesn't exist. As everyone knows, the hardest thing to do is to change culture. So if you don't have the right personalities with orthopedics and neurosurgery working together, it can be. So if you're interested in this kind of stuff, go in and take a job.
Let's have that first.
Really look into.
How much do you use spinal navigational techniques in your surgery in smaller children?
That's a great question. So I love navigation, but for cervical spine, for upper cervical spine work, the only time I use navigation is if I'm putting in subaxial pedicle screws, because the anatomical landmarks and stuff are more difficult to place those screws accurately. But the difficulty with navigation in very young children is that the spine, unlike the thoracic spine, which is more rigid because of the rib cage, in the cervical spine, it's much more flexible. So I learned that I would put in the retractor, do the exposure, get everything set up, and I'd do this, and then I'd take the retractor out and I'd do the spin. And then I'd come in and put the retractor back in, and it was always off by like 3 or 4 millimeters. And I'm like, what the heck's going on here? And then I realized that it's just because placing the retractor and pushing the muscles to the side lifts the spine up enough in a young child like this, and then your navigation's off by 3 or 4 millimeters. And when you're putting in the transarticular screw and you got the vert a millimeter away, then the navigation wasn't really accurate. So I don't use navigation for most of my cervical spine procedures. The only time I use it typically is for, like I said, subaxial pedicle screws. But thoracolumbar, I love navigation. Don't get me wrong, I love navigation. It's just it's less effective in these young children, I think. What's that?
Very nice. Are there any questions online that anybody on Zoom have a question? Maybe give you a second to.
I have a question about your statement that you have to have a national and international results. I wanted to write an article of what is the cause of failed spine, and I reviewed all this, and I couldn't find that because there are too many things. Is averages out. If you were to find out what the temperature of US is and you average it out, you find something 60. You wouldn't find what California is. And the same thing with the art of surgery. I would have liked to, if I were to do painting, I wanted to know what was about Michelangelo, which was exceptional. Or if I wanted to do basketball, I wanted to know what Jackson was, besides being taller. So sometimes individual, when work on something, and they do the best. Say if the mortality of a center is considerably less than another center. As a student, I wanted to know what they did, but I wouldn't get it from a statistical.
It's a great point. That's the power of the registries, because that's exactly why we need registry. Because then you can do a study with the patients in the registry and you can find out if the outcomes of the children at some centers are not as good as the outcomes of children at other centers. Then you can figure out what the good centers are doing to try to replicate that, and you can share that information with the centers where the outcomes aren't as good. And maybe it's something as simple as in different countries, they don't have access to the same equipment that we have, but it might not be. It may be that other centers are using, always using structural rib autograft and other centers aren't. So that's your point is extremely well taken, and that's exactly the point of the registry.
Good. Okay. Do we have a 5-minute coffee break? Is that? Welcome back, everybody. Thank you. That was a fantastic first talk, and just wanted to move on to our next guest speaker. We have two, excellent guest speakers. One, Dr. Anderson, a clinical neurosurgeon, specializing in spine surgery, and now I'd like to introduce Dr. Huber Fong from Johns Hopkins. So. She completed medical school at Ohio State, and then from there went on to Wash U to do residency, and then went to Johns Hopkins and started there in the early 2000s, where she did a PhD and started on as faculty, and has been there since, and has worked up through the ranks as a scientist and clinician, and is now the director of the Greenberg Center for Esophageal Dysplasias. She's not a surgeon, and I think the first thing when we first asked her to come, she said, is this specifically for surgeons? And I think the real thing is that even though Dr. Frim and his patients, were surgically related, the program is really not just a surgical-based disease, and I think that's really important to know. And really, patients with these various conditions are mostly taken care of non-surgically, so I think that's really important to know. And Dr. Huber Fong is really an expert in all these related things.
Thank you. Hi, everybody. Let me know if anyone can't hear online or whatever, and we'll adjust as needed. I wanted to say thank you to the Hackett family and the whole consortium for the invitation to talk here. This type of topic is near and dear to my heart. We run many multidisciplinary clinics, and I'm particularly interested in all bone conditions, and the central theme is certainly the dysplasia. So I welcome opportunities to do this, and then hopefully to have more conversations about collaborations and moving forward with things. So here's my disclosures. I always use Google Images unless I note that it's a particular lecture. I do have consulting work that I do. I'm not really going to talk about results so much from any of those things. I am going to talk about the investigational use of these medications, but everything's publicly available, okay? And all of it had to be reviewed by my institution, as we all need to do these days. 3 big parts: history. I'm going to talk a little bit about the organization of the genetic skeletal disorders, how things fit in, and how we define these diagnoses. Progress on the natural history side of things, and I'm specifically going to talk about achondroplasia, but I'm also going to throw in a little bit about hypochondroplasia, hypophosphatasia, a metabolic bone condition, because it's a really good example of how a condition was known for a very, very long time. And then there has been a treatment that was really a game changer in the care of those patients. And then future for new therapies and treatment guidelines, because couldn't agree more, having a guideline, having a map for families, healthcare providers, for insurance companies to fight the good fight that things are necessary for patients. That's another big piece for that. So a little bit on the history of things, the organization itself. So you can think of genetic skeletal conditions in these 3 big groups: dysplasias, metabolic bone conditions, and dysostoses. Dysplasias is probably one of the easier ones to think about. So if you've got a condition that the cartilaginous onlogin is abnormal and you're going to put down bone in an abnormal way for that, perfect example is achondroplasia. If the bony backbone is abnormal, then you've got something like osteogenesis imperfecta, and those are dysplasias. And in general, those conditions have abnormalities from head to toe, okay? In the center section, metabolic conditions, that can be anything: vitamin D issues, enzyme issues. You're not making either the backbone well, or more likely it's the mineralization that's an issue. And hypophosphatasia is our example there. And I'm not really going to cover dysostoses, but that whole group, that 3rd group, are bone conditions that don't necessarily go head to toe. So perfect examples would be a palatal defect, or synostosis, or Neil patella syndrome, which we've done a lot of work at Hopkins on in the past. So elbows, patella are infected, but pretty much nothing else. So those are our 3 big groups. So on the organizational side of things, several decades ago, there were people who were trying to sort of lump and group people and define different diagnoses and things. And around the 70s, 60s, 70s, this group of people in particular, and a few others around the world, said, we've got to organize this. Somehow we've got to figure out that short limbs is more than just achondroplasia, and a long trunk but short limbs is a little bit more than Morchio, and we've got to organize. So in 1970, there was the first nosology, or order of the genetic skeletal conditions. There were 122 at that time that were recognized. And the key take home here is that only 1% we knew the genetic cause for was Turner syndrome. Turner syndrome was thrown in with this group. Over the years, new variations came out from this, and I skipped a few that were in between here, but for landmarks, 2007, there were 400 disorders that were considered within the genetic skeletal disorders, and we knew the genetic cause for about 50%. Progress, 2019, 461 and 92% with a genetic cause known. And then just literally a couple months ago, we have a new distinction, a new nosology, where there's over 700 different genetic skeletal conditions. Remember, that includes all 3 of them, from with about 500 genes, and we know the genetic cause for 99%. Now, to put this in context, wearing my geneticist hat, we all have 20,000 genes. Right now, we really only understand the function of those in about 25%, a third if you are generous with the way you categorize them. So because of this big effort to group patients and to really define, like, here's the features of this condition, that's how progress was made so dramatically, where in this group of conditions, we know the genetic cause for them. And this is really helpful for families, for healthcare, but then also to understand what's going on in the bone so that we can have some impact in treatment, and then also to just understand the condition so that we have a better impact in management. And I differentiate those two through this talk as treatment. It's something that you're giving to the patient, and management is everything else, okay? So dysplasias and metabolic conditions, that's what we're gonna focus on. And I'm gonna give a little bit of history here, again, of how we got to this point, because the LPA, and I guess I'm sort of tooting our own horn here for Hopkins, we played a big role in some of the progress of the skeletal dysplasia study, not discounting any other sites that did anything, but I'm going to tell the story from this perspective. So two individuals here, this is Victor McCusick over on the left, and Billy Barty here on the right. So let me tell you their stories. Dr. McCusick joined the Hopkins faculty back in the 40s. He was a cardiologist first, and he studied Marfan syndrome, connective tissue things, and very into auscultation of the heart and differentiating different congenital and later abnormalities with heart function. And he developed an interest in human genetics, and thankfully he did. Organizing and describing these conditions later became MIM, which was the books, Mendelian Inheritance in Man, and then it became online, Mendelian Inheritance in Man. Does anybody use that to search for conditions? I see some nodding there. It's a very good resource. It's created and maintained by a group of people at Hopkins that go through medical literature and then update this database, and it's world accessible and it's free. So it's a great resource. So he played the major role in starting that. And then trying to map the chromosomal location of all these different genes, that was sort of a boot into the Human Genome Project, which is right at the beginning of the 2000s to figure out all the genes that we have. And then he became the director of the Moore Clinic and decided to sort of refocus that particular clinic at Hopkins from chronic diseases into hereditary conditions. And here's a picture of him photographing some patients, a little girl with EBC, Ellis Van Creveld's condition. And the more reputation grew and more people started to come. And he very often had his camera and his little brown notebook that he had in his pocket there to see patients in the field, particularly old order Amish, and that was a very useful and directed population that he studied because of the consanguinity. There was a higher chance of having recessive conditions within that population. He recognized that, so he did that. Around that same time, this gentleman, Billy Barty, he had been active in movies and was moving into television. And the story as lore, as I've been told, is that he was on the Art Linkletter show in 1957. And Art Linkletter asked him, what's difficult about being a little person? And he said, well, you know, it's difficult to meet other people who have short stature. It's kind of lonely. It'd be nice to meet other people. And the story is that he looked into the camera and said, you know, anybody who comes to Reno on this particular day next week, I'll buy you dinner. And so 16 people showed up, and this is a picture of them. This is from the archives at Hopkins, and then there are some other images. I actually think I threw one in. Yep, here we go. This is from the Little People of America archives. This is a group of people, and you can see for reference the average stature person here. Some of these individuals have pituitary dwarfism, so it's just growth hormone deficiency, some achondroplasia, cartilage hair hypoplasia, Billy Barty. And these folks all met here, and this really is what prompted Little People of America group to be formed. Billy Barty is the founder of that. And over time went on here, more people joined, they set up a system of districts and then regions and then a national thing. And by the time we got to the 60s, there were about 700 people. And now it's the largest patient support group for short stature individuals. That's about 8,000 people in it. And there are LP UK, LP Canada, LP, all kinds of places. And there are efforts on behalf of the LPA to try to unite those people in different ways to support their groups. Lots of progress in terms of advocacy, people meeting each other. There's the Dwarf Games, the Dwarf Athletic Association of America. Next year's a global event that happens for that. Lots of support systems, education, scholarships. We give scholarships and things like that. And a tremendous teaching opportunity. We take our trainees to those opportunities. So time goes on. They're both making progress here. And fortunately, in 1965, the two met. So there was an article in Time magazine about Dr. McCusick talking about study of Amish patients and skeletal dysplasias and the work they were doing. And some LPA board members visited Dr. McCusick, said, hey, you know, we've got this organization, please come. This is a picture of them in front of an old-fashioned Holiday Inn sign, if anybody remembers what those look like, out in Gloucester City, New Jersey. And he then decided, okay, I'm doing this Moore Clinic from a hereditary disease standpoint. I'm going to sort of push it further into dysplasias. And then the LPA conference became an annual event, and lots of progress went forward from there. Different feet. representing both of them. And in fact, one of the LPAs was at Hopkins. This is at one of the sites on our undergrad campus, the Evergreen House. And I have to make the point here that I could not ever find Dr. McCusick in here. I've had many people look at this picture. We think he took the picture. He was very big into doing this sort of thing and not actually including himself in that. So this is one of the big events that happened at Hopkins. And concurrent with that, Dr. McCusick also developed some other educational symposia. And I've got a little bit of history on that that I'll skip over, but the population of people keeps getting bigger on these steps out here. And there, whoops, right there. And I find it interesting as I've looked through some of these archival things, the topics that the families want to discuss are exactly the same that we discussed at the LPA events. So controversies about treatment. At that time, it was controversy about growth hormone. And that if you took away someone's short stature, would they still belong? Would they still be part of the group? Interesting. Same thing, parallel with the drug therapies. Average or short stature parents having average stature kids. There are sessions about that at everyone. So I find that interesting that some things never change. Again, there were more articles that were published about Dr. McCusick's work. And fortunately, Mr. and Mrs. Greenberg, Alan and Catherine Greenberg, saw some of those and started a relationship with Dr. McCusick and the right-hand person here, Mrs. Kay Smith, building that and established a Greenberg Center, which fortunately I had the great opportunity to come on as clinical director and then director as Dr. McCusick had passed away in 2008. And we were busy. We're busy, and I'm thankful to people who allowed me to come to their sites and hang out with them and learn about dysplasias. And we resumed doing consultations at the LPA events, started scholarships, restarted our internal communication among our specialists. Lots of mentees we've taken to these events, and they're just really wonderful. So a few thousand people that come to these each year, and then we also do smaller regional and district events as well. And now with our big umbrella here, going over metabolic conditions and with the dysplasias and the dysostoses, this is some of our research teams, some of our key players clinically, and I'm just thrilled that we can work together with these patients. These are some of our other individuals. Our counselors are key in the management of our dysostoses, and Kim Seifert, the nurse here, also expanding into the craniofacial disorders and clefts and orofacial clefting. So we've got huge things going in research, education, and clinical care, and lots of patients, and still lots and lots more to see. So now we've got this giant umbrella over all of it. Very basic do's and don'ts. Anytime I give a lecture, I always want to throw this out here for basic communication things. These are appropriate terms to use for short stature individuals. LP, little person. We use the term short stature. I'm average stature. I'm not normal, because if I'm normal, then my patients would all be abnormal. They're not abnormal. They're short. I'm average. So this terminology that we use. We do not use the term midget. It's considered incredibly derogatory within the community. So we do not use that. And then the other things are just sort of first things that we strive to use in genetics in general. Mary has achondroplasia and she's in this room, not the achon in such and such room. Okay, progress. Natural history management and treatment things. For, again, perspective on things. Achondroplasia is the most common short stature dysplasia. Out of that new nosology, as I mentioned, there's 700 different genetic skeletal conditions. Now it's around 400-ish short stature dysplasias that are included as part of that. Achondroplasia, 1 in 20,000 to 30,000. If you put all of those short stature dysplasias together, though, you're at around 1 in 4,000 to 1 in 5,000. And I had taken a slide out, but I want to impress upon everybody a key part about this 400 different dysplasias. Achondroplasia probably represents 50 to 60% of all of them. If you could fill a whole stadium with people with short stature dysplasias, it's probably only a dozen to a dozen and a half other dysplasias that'll get you to 90, 95%. So there's 5 to 10% that have these rarer conditions. Not saying they're not important. I find those very interesting. Love to help families with those. But if you have a GRIP or treatment guidelines, you know, for a dozen conditions or a dozen and a half, it probably really covers the majority of the short stature dysplasia patients. This is a condition that's 100% penetrant. That means if you've got the gene, the change in the gene in one copy, you have it. and 80% of individuals are born to average stature people. The key features, clinicians in the audience may be very well aware of all of these, but I'll kind of go through these. These are the key features. Final adult height is somewhere between 4 and 6 standard deviations below the mean. You've got macrocephaly, a large head, frontal bossing here, mid-face hypoplasia that plays some kind of a role in obstructive sleep apnea. Rhizomelic means the root of the limb. There's also shortening of all the other components, but it's considered a rhizomelic dysplasia. The metaphysis is what's affected, not so much the epiphysis or the spine here, but the metaphysis. Short fingers, thoracolumbar kyphosis, lordosis, varus deformity, tibial bowing, and as I mentioned, a metaphyseal dysplasia. So just a few quick radiographs. I have always an average stature child comparable to the age, close to the age for comparison. So this is showing the metaphyseal changes. This is showing the pathognomonic feature of if you're not sure about a diagnosis of someone with achondroplasia or even hypochondroplasia, one radiograph of the pelvis will show this small sacrosciatic notch. That is the same thing as what you see here in the average stature person. And then the iliac bones are very rounded and very large. So that's classic also. This image of, it looks like an ice cream scooper, the proximal femora are kind of carved out here, and you can see how that's different than average stature. And often some delay, even though the age is comparable in the epiphyses. Interpedicular narrowing as you get down into the lumbar spine. This is classic for achondroplasia, against one of those other features from a film that you can differentiate that. And that narrowing, along with the lordosis, along with weight in individuals as they get into adulthood, is what contributes greatly to the back pain and issues that adults have with achondroplasia. I set this up so the black part, I apologize if anyone's colorblind, the bullet, if you can't see the red, well, I guess there's no green in it, so it should be okay. The part with the bullet is the feature that's abnormal, and then what's done to basically manage it at this point. So a very misshapen foramen magnum with stenosis, compression can cause all sorts of long track signs, central apnea, and decompression often is what is needed. Obstructive central sleep apnea, where you can treat with tonsillectomy, adenoidectomy, and CPAP then. Continuous airway pressure here, if not good. Spinal stenosis, greatest problems for our adults, and sometimes weight loss physical therapy can work, and you can avoid some surgical decompression, but sometimes that's the only choice. The thoracolumbar kyphosis, we do a lot of education early on with the kids families with the kids to not have a lot of unsupported sitting from very early on. The size of the head and the lower tone centrally can really exacerbate the thoracolumbar kyphosis, and you can have deformities there that make it even more difficult to manage. So avoiding that. The varus deformity with the overgrowth of the fibula and the abnormalities of the metaphyses in the knees, sometimes osteotomies are needed. Weight loss sometimes can help that. Recurrent otitis media, or sometimes just chronic fluid behind the TMs, can really inhibit language development. So tubes are very often needed. And we always talk about jugular bulb dehiscence as well, because the jugular bulbs sometimes are displaced a little bit above the TMs. And if an individual maybe comes to us only one time for multidisciplinary care and they can't come back for regular care, we want them to know that that high probability, over 50% chance they're going to need tubes, that their home ENT needs to know about that before they put the trocar in and put the tube in, that it's possible in a few percentage points of people with achondroplasia that it could be displaced. And then I throw out this here, and we'll talk more about this, that some people consider short stature as a complication of achondroplasia. Some people feel like it's just part of it, and that's just who they are. So because of that, some people feel limb lengthening procedures, growth hormone, which really isn't effective in achondroplasia. And these new pharmacologic treatments are treatment, but not everyone. So we'll come back to that in a second. Put that up there. I included this image. If you or anybody knows where this originally came from, I would love to cite it. I use this image a lot, had a lot of discussions with people over the years. It is published as such in this article, but I don't know where it came from originally. So if anyone knows, please tell me. But this is to show the difference, of course, of the foramen magnum between our patients with achondroplasia and average stature. One of the shapes that can be seen there, causing the greatest mortality in our younger kids and morbidity in the older in the spine. I threw this in here just because these are issues, things we just talked about here. They're through your whole life potentially. So seeing someone once isn't really doing them justice. And these things pop up at different times. You can have complications further after you've had a surgical procedure, all of these things. So that's the take home point. Big fan, I'm a huge fan of natural history studies. This was a wonderful opportunity as some pharmaceutical companies were developing drugs and treatment for patients with achondroplasia. It became clear that what has been published up to that point was single center studies and not really anything largely coordinated to really get a good idea of how often are these surgeries really done. The medications that have been developed most recently for achondroplasia, the outcomes are based purely on height, which makes sense from a study design standpoint. You have to have an outcome that's proximate to be able to say after 1 year or a year and a half, was there a difference? Is this worthwhile? Many people were hopeful that if there is something that changes from a growth perspective for these individuals, maybe it will have some sort of effect down the road where maybe they won't have to have as many back surgeries, or maybe if it's treated earlier, with growth, maybe the synchondroses at the base of the skull won't close as early, and maybe they won't need a foramen magnum decompression. We're not going to know that for quite some time. You can't design a study with primary outcomes 20 years from now. So that's why they're based on height. But before we could even say anything about whether or not the medications have some positive or negative influence on that, it really wasn't known on a population basis how often these problems actually occurred. So that was the whole thought behind building this database. And it is something that I had not been able to get funding for, to pull data together from multiple institutions to be able to say it more nationally data-wise. And in applying for independent grant funding through pharmaceutical companies, we were able to do it. So it was a way to leverage things, and they have no say over what we publish at all, how we do anything with it. But now those companies that have funded it can use the publications for their own work, for their development, like going to the FDA and things. So it's worked out well for us. Okay, so natural history study, we got almost 1,400 people with achondroplasia in this registry. Of those individuals, you can see how many total surgeries they had, and almost 80% had at least one or more achondroplasia-related surgeries. ENT surgeries, tubes, tonsils, adenoids. Brain, that's a larger thing, there's more detail in the paper, but that could be shunt, ventriculostomy, a variety of things. Foramen magnum, including foramen magnum, plus minus C1 or C2. Spine, everything from below C2 down, and then extremity surgeries. So not an insignificant thing. From this database, we've also published some new growth curves that have more population in it than the original ones and are not hand smooth. Colleagues have done some very specific developmental charts for achondroplasia. This one's a fabulous one from some colleagues in Australia that did that. So big take-home points: greatest morbidity, mortality listed here. Complications are really through the lifespan. People deserve longitudinal care. Tremendous surgical burden, and that controversy about whether or not short stature is really a complication. Okay, looking towards the future, as I said, I split this into achondroplasia, but I have a few slides here for hypochondroplasia. I know we started a few minutes late. How much time do I have?
As long as you need.
Well, I could talk for 2 days. What time do you want me to end?
You don't know Julie well enough. Give her
20 minutes. 15, 20 minutes.
20 minutes. They need questions.
Okay, and I'm around too if anybody has questions. So I'm a geneticist. I can't not show like a gene thing and mechanisms and things. Okay, so just to put everybody on the same page, the gene that causes achondroplasia is called FGFR3, fibroblast growth factor receptor 3. And that gene makes a protein that's out here. This is what the structure is. And this is normal function. There are growth factors that are floating around, and they connect with the receptor. The receptor dimerizes like this, connects, and then intracellular signaling happens. And the normal function of FGFR3 is that it slows down growth, foot on the brake. That's normal. It inhibits chondrocyte proliferation, terminal differentiation, and that's why there's slowdown of growth, and this just happens to balance with other trophic factors that allow growth. The issue in achondroplasia is that if you, I'm sorry, I forgot to talk about the rest of the mechanism. Once you've got that intracellular signaling, that message to slow down growth gets stopped because the intracellularly it gets ubiquitinated, it goes to the lysosome and it gets broken down. So the message stops. Okay. In achondroplasia and the other related conditions, there are mutations in the gene that cause a problem here at the transmembrane domain intracellularly, or sometimes even with the ubiquitination process, so that in achondroplasia, that message, the normal message, slow down growth, is turned on all the time, excessively so, and it doesn't get turned off appropriately. That's why you have short stature. So all the other treatments that have been developed are being designed to alter places in this pathway where you have this slowdown of growth. So let me move forward one more. This is the same receptor up here. These are these fibroblast growth factors. They come along here, it makes it dimerize, and then you've got intracellular signaling in here that does the slow down growth, and to this excessive amount. The new treatments that have come about try to interfere with either making intracellular tyrosine kinase active, or in different ways adding C-natriuretic peptide, which goes to natriuretic peptide receptor B here, and then inhibits the inhibition. If you inhibit the inhibition, you allow growth. Okay. So of the new treatments that have come out, IP stands for investigational pharmaceutical, the mechanism, and then where are the trials right now? I'm going to go through just a couple of those. Infigratinib is a tyrosine kinase inhibitor. This one has been developed pretty darn quickly because it's already been used in cancers. Tyrosine kinase inhibitors is a group of chemotherapeutic agents that's very heavily used. And in achondroplasia mouse model, it showed that the drug actually penetrated the growth plate and the organizational structure of the chondrocytes greatly improved, and then the long bones grew. So this trial has moved forward and it's in phase 2 right now, plans for phase 3 towards the end of the year. And again, publicly available. Early results in the phase 2 showed that there was an increase of about 3 centimeters per year for the individuals who were treated with this medication. For reference point, average stature individuals obviously have really high height velocity when they're born. It drops down to where it's like in that 7 to 8 centimeter range. When you're from 5 to 10, you hit puberty and you have a big growth spurt, and then it kind of wanes after that. In achondroplasia, you still have a high velocity early on, but it's about half that of what it is in average stature. And then that level part around 5 years of age is around 4 centimeters. And then there's no pubertal growth spurt, but growth happens for many, many years after it. So these medications are tailored and not really designed, like the studies are being designed to hit those different growth points at different times. Okay, so 3 centimeters per year on top of typical growth of 4 centimeters, actually kind of a lot. I don't know if this will be sustained. This is just first go round for this, but that's where this stands. And the company is called QED and Bridge Bio. Then on this other side with this C-natriuretic peptide business over here, there are 2 companies that have developed things. So a couple of decades ago, there were actually people, Yasada and Lorget. They figured out that C-natriuretic peptide, if you gave it in a constant infusion, normalized growth in an achondroplasia mouse model. But there wasn't an effective way to give continuous medications to individuals with achondroplasia. So it kind of went by the wayside until more recently, when 2 companies did 2 different things to C-natriuretic peptide to make it last longer, basically. So this particular company developed something that the C-natriuretic peptide could just last longer. And this has actually now become approved by Marin as the company that developed it. It's by an injection. I didn't mention the one before, it's an oral medication by injection, and it's now approved in several places in the world. And there are ongoing studies until people reach final adult height. And again, it's through this natriuretic peptide receptor B thing. Additional growth for this particular substance is about 1.5 centimeters per year, but they have the data now to show that it's sustained over about 6 years. So they were earlier and sustained. The last one I'll mention here, this is a company that it's Ascendis, and they have been using this, it's basically a carrier for various drugs that just make it last longer. They're called TransCon. So they've done the same thing with C-natriuretic peptide, and it lasts longer, and they have ongoing trials as well. And this is now only a weekly injection. So different modalities, different ways, different things going on there. I have one slide here that this is just to show that there are several other companies that are trying to develop other things here, different ways of hitting that same pathway. Aptamers, other tyrosine kinase inhibitors, theobromomeclizine, which is an anti-nausea medicine that's already out there. So those things are in the works. Also, so I've talked about treatment, but also for management. This is a group of individuals that we got together a few years ago, and we decided that we wanted to make treatment guidelines for people. We started off with a focus for achondroplasia, but we really want for all skeletal dysplasias. This has been a wonderful opportunity, bringing together people from various places in the world and making some real papers through a Delphi process that insurance companies recognize, professional organizations now use as their required reading, and our patients very much appreciate them. We're in the process right now of translating these into checkoff lists for healthcare providers for faster use and for families. And you can see we added some things that kind of cross over here in foramen magnum, basic perioperative management. The pregnancy one became a very popular one because you can imagine that there are a couple of people in the country that are experts in pregnancy of women with short stature dysplasias, but someone who's pregnant can't fly, every week for visits and things like this. So this has become very, very helpful for people all over the place. Type 2 collagen conditions, that's probably the second big group of short stature dysplasias. And that one covers global care for those individuals. Craniofacial aspects and spinal disorders for management for that as well. I am going to mention a little bit about hypophosphatemia and then just a few thoughts to close things out. Hypophosphatemia is a very common metabolic condition affecting bones primarily. It's been known for decades, over 100 years. And what's unique about it and what made progress happen fast for this is that a classic, very specific marker for this condition is having very low alkaline phosphatase. And alkaline phosphatase, as everybody knows, that's part of a complete metabolic panel everywhere. So it's a very well-known marker. And what held things up a little bit is that many times in lab results that we get, things are marked if they're high, but not necessarily if they're low. So this is an issue where alkaline phosphatase is not made properly. So it's very, very low, but very often people don't even know that they have the diagnosis. I will say that recently with this new treatment that's here, an enzyme replacement therapy, there's a lot of interest in identifying people with this condition that have a very, very specific treatment, who are sort of lingering away, like in rheumatology clinics or in orthopedic clinics because they've got non-union of fractures. So let me share a little bit of information about this. It's somewhere in the rare to ultra rare category. Maybe it will end up being less rare as more people are tested for it, but low alkaline phosphatase is the hallmark. And you can see here that's been known for a long time. This is the name of the gene, tissue nonspecific alkaline phosphatase. Unique thing about this is that there are dominant forms and recessive forms. Remember, dominant, you have to have one abnormal copy. Recessive, you have to have two abnormal copies. The two abnormal copies seem to be the most severe end of the spectrum. A dominant one where it's not loss of function, but gain of function, kind of like what we talked about for achondroplasia. That's what causes the pathology. This is the key take home for hypophosphatemia, is that when we're young and our bones are still growing, our levels of alkaline phosphatase are higher. As we get older and our epiphyses close and everything, then 40 is the norm for adults with hypophosphatemia and not like average individuals. It's important that we use this graded normative curve to identify people with hypophosphatemia. And the characteristic features here are fractures that occur without really marked trauma, very poor healing, non-union of fractures. I included this picture here because this is actually an individual where the dura is, this person has hydrocephalus, and the dura is actually ossified but the cranium itself isn't so excessively large that would make you hone in for this. And having these open epiphyses, kind of like in cleidocranial dysplasia, this is what you see in hypophosphatasia. You can have seizures, terrible pulmonary insufficiency because the ribs aren't well formed. So if you don't have the ribs, you don't have the musculature that you can breathe. And this is actually a picture of a baby tooth. Because the cementum is very affected, the whole tooth falls out and often falls out very early in young children. So these are sort of your classic features. I'll say here that there are other features for individuals with hypophosphatasia, specifically in the neurologic realm, because the same enzyme is needed to move B6 in. So you in essence have a deficiency of B6. And then this chronic pain issue that so many of the patients have, that is dramatically improved by the enzyme replacement therapy is key. And the natural history of hypophosphatasia is also that you are more prone to having nephrolithiasis because of the elevated levels of calcium and phosphorus. There's a whole spectrum here, a disease severity from perinatal lethal up to adults that have non-unions and then only teeth manifestations. This is the key picture here from the early, I think it was 2012 or 2011, 2012. So this is an infant with, this is an infant with hypophosphatasia that was the perinatal lethal form. You can see no bones in the hand, terrible, long, gracile ribs, very irregular, poorly supported. You can see similar issues here, the fraying of the metaphyses and the leg and things. Just 24 weeks of therapy. They have ribs, they have bones. I didn't include the other picture of the cranium, but they have a cranium. We in fact have a neonatal lethal patient that we're following that is thriving. He's 2.5 and running, thriving, has a cranium. It's just fabulous. So a whole spectrum, really severe end of the spectrum on the infantile side, complete and total game changer for those with the infantile, the childhood forms, and adults that had manifestations in childhood, because right now the indications are for treatment up through if you had symptoms by the time you were 20. You can see these fractures here, and the teeth abnormalities are just tremendous. So I threw this in here also. There are some other reasons why a person can have low alkaline phosphatase. You can see the listed here that it's largely related to nutritional deficiencies, sometimes hypothyroidism, so endocrine issues can be there. Cleidocranial dysplasia, we've got a huge natural history study going right now with cleidocranial dysplasia, and we are finding a lot of low alkaline phosphatase in those individuals. We're trying to tie that into some of the bone pain things as well, but there are other causes for this. And for those individuals, this enzyme replacement isn't effective. By and large, management was symptomatic. So as there were manifestations, treating those as needed, an absolute game changer with the treatment with the enzyme replacement recently called Strinzi. It's an enzyme replacement and it's widely available through the country. One other key take home from a bone perspective, since we're talking about rare conditions, in hypophosphatasia, your problem is that you're not making bone appropriately. Everybody here, I'm certain, has seen all the commercials on TV for the things, the medications for women, middle-aged women with low bone density to prevent fractures, bisphosphonates. We see all those commercials. It is absolutely contraindicated to treat individuals with hypophosphatasia with bisphosphonates because the bisphosphonates shut down the resorption part of the bone. All of our bones, we make bone and resorb bone constantly till the early 20s. And then after the early 20s, it's downhill. From there, it's still remodeling and things, but we're just losing bone. If you give bisphosphonates, you shut that down. And if you have hypophosphatasia, you shut down the front part also. So this is the other big reason to work hard to identify individuals who have osteoporosis, but have it for this reason, because the treatment is so specific. The future, tremendous progress, it has been made. This is so exciting to be in this place right now where we definitely have management things, but now potentially we have some treatments in certain genetic skeletal conditions. There are several approved therapies right now. I didn't put this up here so we could look in every detail, but it is in an article that we wrote for American Journal of Medical Genetics to celebrate Dr. McKusick's 100th birthday. These are all genetic skeletal conditions, many of them metabolic, that are treated now, commercially available prescriptions, game changers for individuals with these inborn errors of metabolism, inborn errors of genetic skeletal conditions. Second page, it listed the ones here that were in progress. And from a dysplasia standpoint, there was a trial that has now stopped for pseudoachondroplasia, hopefully a new one to start. Schmidt metaphyseal dysplasia, which is type 10 collagen condition, was actually repurposing Tegretol. It seems to really change the inflammation there. Some of the type 2 collagen conditions are now being worked up in a registry for gene therapy. And for those individuals, this has the potential to really be something. Anybody who sees type 2 collagen patients, that have had to have their hips replaced and their knees and their spine and cervical instability and everything, if this could actually change something for that, that would be huge for them. Dystrophic dysplasia, that one has not ever moved forward. And then fibrodysplasia ossificans progressiva, there was a trial for that. Some of it is on hold. That's a pretty significant condition where the soft tissue becomes bone. Even though we know a lot about these different conditions, I already said I'm a big fan of natural history studies. We have to understand the natural history, but we also need to really understand from our patients what matters to them. And this whole thing that's happened in the last decades with these new medications has really taught me a lot about listening to my patients and not just assuming that people want things that we think are the right thing or the good thing to come forward. I have to say that we're just starting to really understand quality of life things and how to ascertain that and how to get that from an individual and then be able to meet them at the right place with what these other therapies could potentially be. And I can't say enough how I've learned in the last few years the tremendous global differences in access to healthcare and therefore access to medications and access to expertise that exists not just in the United States, but tremendously around the world. And for that reason, I do think that some of these developments for some of the medications, that may be easier to get out in some ways if we can get past the monetary part of it than the healthcare parts of things, but they have to meld together. People can't do these in isolation. And I feel like patients with these complex diseases just absolutely deserve multidisciplinary care. And frankly, it's more fun to offer multidisciplinary care when you can actually sit around the table with your colleagues from other disciplines and do the right thing by the patient. And I wanted to add that picture there. That's the dome at Johns Hopkins and one of our great patients there. And thanks everybody for your attention. I'll take any questions.
Very nice. Thank you very much for that, really nice overview, especially for people who aren't experts in everything, understanding the treatment and the genetics and the molecular underpinning. So questions, please.
Thank you very much. I learned a lot from that. That was a great talk. What are your thoughts on achondroplasia and hydrocephalus? So, I think you mentioned roughly 10% of children with achondroplasia having hydrocephalus, but not all of those are due. A lot of them, most are not due to an obstructive lesion, like they don't have a tight cervical junction. Any thoughts on why those patients are getting hydrocephalus? Is it an issue with the venous pressure? Is it? If it's a purely skeletal disease, why are these patients getting hydrocephalus?
I don't know.
The reason is the jugular bulb, the outlet is narrow as well, doesn't it just affect the foramen magnum? And because of that, they have high venous pressure. And now the issue of whether it's obstructive or not becomes actually very complex.
That's what's not known.
Well, it becomes very complex because it's our definition of obstructive versus communicating hydrocephalus is very simplified. So the initial paper that was done on achondroplasia patients who had obstructive hydrocephalus was ones who had either tonsillar herniation or posterior fossa arachnoid cysts, etc. What it really wasn't looking at the mechanism of hydrocephalus. These were kids who had other issues. However, the way these kids essentially survive is because there's other pathways of outflow for the venous blood. It's not just the jugular ball, although that's the main area. And so they develop lots of pathways through the dura, accessory pathways. And this has been documented and shown on venous studies. So they have increased outflow through the dura at the cervical medullary junction, and outflow through the veins around the nerve roots. And so they also have some degree of obstructive hydrocephalus in that the kids who have cervical medullary stenosis or the small posterior fossa, they have obstruction of venous outflow at the cervical medullary junction. So in those kids, there is some degree of obstructive hydrocephalus, even though it's venous, it is also obstructive in that if you do a decompression, now you're decreasing the venous pressure and actually almost immediately. So in those kids, you actually see the fontanelle all of a sudden dramatically improve. Now, is that enough to overcome the jugular bulb stenosis and outflow or not? So only in those kids you can kind of affect things, only in those kids. Now, the other part is how small is the posterior fossa, the tonsillar herniation and obstruction, CSF outflow as well. So it becomes multifactorial. This is something that Julie and I have discussed forever and ever, and it's an interesting thing, but we don't really look for it. We have to kind of think about all these things when we're dealing with it.
So do you think we should look at venograms for all kids that we have? No, not all kids, right? But kids that we're special, we should have hydrocephalus as a main treatment for. Should we be doing venograms, looking at the venous outflow, potentially considering jugular frame decompression?
So the one or two cases where this was tried, and one was at Hopkins, not a good idea. So the soft tissue and the veins, et cetera, in kids with achondroplasia, very high pressure, do a jugular decompression, they've been uniformly fatal, right? There was one in Boston that was done.
The one I know you're talking about wasn't immediately so, but there were a lot of other complications.
Yeah, so not one that is taken lightly. Everyone who's tried it in really good hands with Ben and in Boston with Mike Scott, and everyone was a total disaster.
But to your point, maybe there's a subset where you just do a break back.
Yeah, so on those patients who already, so what we did was, that's why we published that, and the recommendations came out before that. Julie's like, well, you have no data that shows this. I'm like, so that's what made me go back and look at all the kids, and it's not a huge number. In those kids who have foramen magnum stenosis and have hydrocephalus, when you do an adequate decompression, and I'm not meaning the suboccipital craniotomy that some people don't really do a lot of this, but if you do a good foramen magnum far lateral skull-based decompression, in those kids, you either stabilize or improve the hydrocephalus. And we saw that happen in 80% of those kids will already have foramen magnum stenosis. If they don't have foramen magnum stenosis, we haven't gone back because we only operate on symptomatic foramen magnum stenosis because it is a big deal. It's not a small operation. But the thing that it becomes really important in is that when I started doing this, Ben was opening up all of the dura, and that necessitated really cauterizing the posterior fossa dura, where all those accessory veins were going through because they have high venous pressure, it bleeds like crazy. So we stopped completely, and George followed. He doesn't open up the dura at all on any of these now. No one does, and that preserves the venous outflow. It's very important to recognize that. I think that's the biggest take home. Is that in those kids, you want to preserve all of the venous outflow because it does affect the hydrocephalus. Because most of these kids, and then it becomes, what's a big ventricle in someone with achondroplasia?
Right,
when do you really shunt that? And we've really gone away from treating that unless it's continually progressive, high pressure, they're not developing, because a lot of those kids with big ventricles are so borderline and it's venous that when you do shunt them, they have a small fall and a massive subdural. And it's happened to every one of us who's taken care of these kids and put shunts in.
Not to mention the shunt revisions.
Yeah.
So from our natural history study, we looked at that. Now, everybody knows from a retrospective natural history study, we can't say cause and effect. We can talk about trends. We can look at the differences among 4 big sites, that sort of thing. But we have a paper coming out soon that shows that there was far more shunting that was happening, a few decades ago. There was a period of time where at most of the sites, there was even decompression automatically with a shunt. At the same time, there was about an 8-year period.
Because of the leak, because they were trying to prevent the leak. There's so many.
Where it was just like, it was absolutely like with each one of them. And then most recently, for the last decade, now the rate of shunting in at least this cohort of 1,400 people is down to less than 3%. And the decompressions are broader and wider from what we could gather from the operative notes retrospective. Fully recognize it's retrospective. But we also looked at individuals who had hydrocephalus. Was there a difference in the risk of them needing a subsequent spine surgery, a secondary surgery, something from C2 down? And it was actually twice the risk if they'd had something instrumented before, if they had a hydrocephalus repair. Same for cervical medullary junction. And actually saying that they needed spine surgery was the third group. Cervical medullary junction, shunt, ventriculostomy, because we don't have as many of those yet, but it wasn't as high as the other two groups. But
we're
the paper's
trying
coming
to
out.
look at it through the consortium of the ones that we did, because that's the other thing. If it's communicating hydrocephalus, why does third ventriculostomy work on some of these
Yeah.
kids? And we have about 3 or 4. This is very small numbers. I probably see as much as Hopkins does, and those kids, you actually do see significant number where with third ventriculostomy, all their symptoms go away. Not necessarily the ventricles would get smaller. And we're looking at, I'm going to talk about true fists. So we'll kind of get some of those. The question I have for you though, is with the natural history studies and the head circumferences. Did you guys separate out ones with big ventricles, and how did you say who has a big ventricle? It's just who decided what is a big ventricle?
Again, it was retrospective.
Yeah.
So we
So
had
you
to
had
use,
imaging
we had to
studies.
use surrogates of whether they had a surgery for a ventricle issue. We weren't able to look through all 1,400 to be able to say, but we did stratify the growth curves by those who had a surgical procedure and those who didn't. Because there's some thought like, okay, you could slow down the huge OFC increase if you do a decompression or if you do have a shunt or whatever. And there wasn't any difference actually. And we had a couple hundred people who had some kind of surgical
It would be
procedure.
interesting to see what is in terms of venous high pressure, because there are little people who have achondroplasia who actually have normal size, even by our standards
Mhm.
of average height people have normal ventricles and never develop because they don't have high venous pressure.
Yeah,
And if whether you're taking that
There's
aside and
probably more.
saying which percentage have big ventricles because of venosynosis and which don't, now as a prospective one to really get the normograms to the point where
Yeah.
you say, hey, this is someone who we should watch more closely to that question. Who
Yep.
should be watched much more closely. Thank
it's
you.
just the start of that.
Other questions?
Thank you for that question.
Yeah. Huh? Online, yeah.
They asked, if there's been any progress towards Louise Diaz.
Lois Dietz.
Yeah, sorry.
So I'm not part of our Lois Dietz clinic. Those are two in Bart Lois and Hal Dietz are people from Hopkins that figured out the TGF beta signaling pathways for that. I know they use ARBs and I know they use various medications, to decrease, also to decrease pressure, but to help the vascular milieu to not be as susceptible to the aneurysms that happen much earlier in those patients. That's all that I know at this point in terms of other treatments. I don't believe at the second there's a new trial or anything, but I know there are ones in the works. Can't speak to mechanism.
Other questions from the audience here? I think we're going to be awarding a couple of awards for translational research, and they're very basic studies, signaling studies, and I think maybe initially it's hard to see, for potentially the layperson, hard to see even for clinicians how very, very basic research leads to changes. But ultimately, I don't know, when was the gene discovered at GF3?
I don't know the exact year, but it was the 80s.
Okay. It's and just to get to that point, it's probably decades of work, and then the signaling pathway. So I think every little bit of research, basic style research, signaling pathway things becomes critical in that's important to get across. Great, so no other questions, maybe we'll move on. Julie, or- Okay. Welcome back. So the morning scientific session, if you will, is kind of over in some ways, and I just now
We're not
want to
gonna be scientific.
This is really maybe the most important part of the entire program, and for many of you who know the Hackett family, and for others who don't, I think it's time to allow them to be involved in this. Bill Hackett, Raynell Hackett, and Margaret, the namesake of the entire foundation, and the reason we're having all this and the opportunity we have. So I'll just pass it over to Mr. Hackett here.
You got to introduce Bible.
Well, he's one of the most important members of our circle right here.
Yeah.
Is that right, Margaret?
Well, thank you, Dr. Umini, and I really, this is special. It's the fifth symposium. I think this is only the second one we've done live, I believe.
Yeah.
The others online, and what's great is we're not only are we doing this live, but it's also online. So we've got it's is outstanding the way this has grown, and all I can say is thank you to the presenters for you really make this real, and the consortium members that are here. We really appreciate the effort and look forward to continued effort because we've got some great ideas, and I know you have great ideas to continue down the road of developing research and really, as I said last night when we were together, the whole idea behind what we do, the Hackett Family Center and the Hackett Family Program at University of Chicago, is about helping others that are on the same path that we've been on, and that get this diagnosis when Margaret was 18 months of craniometaphyseal dysplasia, and my wife was the medical professional. She's a trauma nurse specialist. She took it upon herself to do a bunch of research, which when Margaret was 18 months old, there wasn't a lot of online opportunities, and we had to fight through to find, understand what the disease was to begin with, find a doctor in France that actually was had treated the disease, because I think when Margaret was diagnosed, she was one of 3 cases in the United States or something.
Yeah, not very many. Some were unidentified, yet some were in the family, but the most of the research came out of Japan.
Right. So it was a path that was not only challenging to understand, and that's part of what we want to do, is help others understand the diagnosis. So we develop research, we develop better understanding, and then find treatment. And my goodness, we went through a battle. I'll let Raynell explain the challenges that the Margaret's diagnosis had presented to the family and certainly to Margaret, but then the further challenges finding treatment and how we ended up here. So I want to say thank you to everybody that's participated, certainly the presenters. Again, it's terrific. And Dr. Umini, I can only say your engagement with this has really helped. And as Dr. Frim stepped back, who was really he's the foundation of what we're doing, because it was his vision and his dream to not just take care of the symptoms of the various diseases, but really understand what was happening and help people. That was his driving vision, and we bought into that years ago, and I said, well, let's do something about it, and this is the result of it. So certainly all credit goes to Dr. Frim, and as he stepped back and you're stepping up, really, it's really been appreciated, and this is terrific, and this is the result of that effort. So thank you very much. Now, as my family has told me, I tend to talk too much, so now I'm going to give them the chance to do a little bit.
Why don't you, so Reno, if you just explain the challenges we had and then the complications of Margaret's disease.
So when she was 18 months old, I asked Bill, I said, can I just go one more time? Well, I'll go to children's. Because I just don't think we know what's going on
Children's in Milwaukee.
in Milwaukee, right? And
yeah,
everybody was treating like the specifics, right? She was hard of hearing, okay? She had a partial Bell's palsy at 3 weeks. So they treat that, but there was no like big picture as it were. So I went to children's and they did a skull x-ray and then they called me in this conference room and there's a bunch of white lab coats. Like, what is going on? So they told me what she had and showed me a picture or something, but they didn't really know how to treat it. They never experienced it before. So I was like, oh my God. So then I went to the medical library and started looking up articles and stuff, and there weren't many. But then I latched on to this Dr. Lyndon Key out of Winston-Salem, North Carolina, and he treated cranial metastasis dysplasia and cranial diaphyseal dysplasia. And he was using calcitriol at the time. And it is have to reabsorb some of that calcium. And so we would go there every 3 months and he'd do bone biopsy in the labs and all that stuff. And he felt that there was some demineralization of the skull. So, but then after that, we went to children's and then they got to the point where they said, you know, we really can't offer her anything here specific to her disease. We can do posterior facet decompressions all day. So
What happened is when she hit puberty, that's when
yeah,
the disease really
that's
exploded.
right.
And all of a sudden she had bony growth, base of her skull, which then was cutting off blood flow and she would pass out. And so we took her down to children's. I think there were 3 procedures that she went, decompression, she went to there, but that wasn't enough. And so we were lost.
So then
how we went to the hydrocephalus.
So we went to this hydrocephalus convention, took this pile of x-rays with us. And I'm like, we can find somebody there, right? So we did a cost a few of professionals and ended up with Dr. Kate. I believe his name was from Arizona, thank you. And he said, look, he said, I would be happy to see her, but this is for the long haul. You have great doctors here in Chicago. You don't really want to come to where? Arizona. So then Margaret saw on TV, she saw a video that Dr. Frim removed the back of this girl's skull and then shaved it down, pieced it together, put it back on a metal frame. And she's like, she choked Dad and I. And so that was it. It was Dr. Frim.
Yeah.
So when we went to him, he didn't know, had never treated anybody.
But yet he was excited.
Yeah.
He wanted to take the challenge.
Yeah, and Dr. Frim never turned anybody away, really. He was very dedicated to his patient population and to anyone who called on him. So that was a wonderful experience. We were there for many years.
Well, then, he jumped into Janet's.
Margaret, what I'll do is I just want to fill a couple of gaps. So part of Margaret's diagnosis is she beyond the cranial metastasis dysplasia or symptoms of the hydrocephalus, she had Chiari, which had to be treated. I don't know how many decompressions. It was in double digits, the number of decompressions, because one of the challenges of cranial metastasis dysplasia is the bony growth on the skull, but the bone grows on the inside and compresses the brain. So it's a constant growth, and it was a real challenge. So again, it was hydrocephalus, Chiari, and then syringomyelia because of the pressure on the fluid flow through the spinal cord. So these were all things that we had to take care of. And again, Dr. Frim stepped up and said, listen, I'm not sure, but I'm willing to do whatever I need to because, that was his spirit. That was the way he was. And so Margaret and Dr. Frim got to know they not only had a great patient doctor relationship. I think it was just a terrific relationship that really, I think it saved all of us, because again, this is not just the patient that deals with this, it's the whole family. The whole family that we had to work through this, and then we've got 2 other children that we had to take care of. Meantime, Margaret was going through she's been through 38 brain and spinal cord surgeries. And finally, the disease, we believe, has burned itself out, which was an expectation that it would burn itself out in the early 20s, and it was about her mid-20s at that. Finally, she's stable, but she's left with obviously all the challenges of the range of spinal cord surgeries and brain surgeries.
I did, my last surgery was 2 years ago.
Yeah.
Yeah, so it's not
But the
necessarily,
shunt was.
so yeah, it's not,
the issue.
it's not necessarily over.
Okay, so Margaret, I'll let you make some comments. Again, I'm talking too much.
Are you talking too much?
I get
So,
that regularly.
You give him a microphone, you'll
So-
want
so, you know, it got to a point of when, in which Dr. Frim, he knew I was doing a lot of research online, and I was in support groups and trying to find out things on like PubMed and different medical sites. And he actually asked me, like, well, if you find any information that's useful, you know, bring it in and we can maybe use it for further medical procedure. And I was like, okay. So when we kind of stabilized and I wasn't in the hospital so much, you know, the idea came about between my dad and I, my mom, and we wanted to have some place where, you know, we would fund research that would further information into these CNS diseases, further the insight into these diseases, and provide better treatment options for those who suffer from these, because we found out in our research that it's about 5% of all newborns are born with CNS anomalies, CNS diseases. So we don't want those families to have to go through that. I don't know, just, you know, we didn't know where to go. We didn't know who to talk to. And it's, you know, you have to get on the right path right away, because if you start off with the wrong surgery, the wrong treatment, you know, you not only have to find your way back to the right path, you have to undo what you did, and it's just a mess. So we're just hoping we can make it better for all those families, so they don't have to go through that.
Thank you, Margaret. And I think that says it all. So we appreciate it. And again, thank you for everyone here, your participation. It just validates the effort that we're making. And she makes a great face for our program. So thank you very much. And I'll turn it back, and we'll get to the real meat of the morning.
Thank you.
I'm surprised Feibel didn't have anything to say. He usually enters.
All right, great. So I did say that in the morning section, but one more talk, and that'll be Dr. Saif Gharlampour. He is actually funded through the Margaret Hackett Family Program, and he's a translational researcher. He's a biomedical engineer, and you know, has a great deal of interest in engineering and fluid dynamics and flow, and the relationship of that and how it translates to improving hydrocephalus management. I think maybe a general idea would be that he studies many different things, but I think maybe the thing that we'll be talking about is about how to maybe how we can non-invasively potentially measure ICP. And I'll give you the floor. Dr. Gharlampour, please. Thank you.
Thank you. Sorry, can you hear me? Computer simulation of CSF dynamics in the management of hydrocephalus. There is no disclosure. Today, we want to talk about non-invasive evaluation of CSF dynamics and recovery behavior of the brain in hydrocephalus using computer simulation. We want to calculate these parameters and we want to compare the changes in these parameters before shunt surgery up to over an extended period of time after shunt surgery. Intracranial pressure, intracranial compliance, CSF stroke volume, CSF pulsatility, and brain stiffness. Thank you, Jess. Hydrocephalus is an imbalance between production and absorption of CSF, cerebrospinal fluid, CSF. After producing CSF, it flows to third ventricle, fourth ventricle, and subarachnoid space. CSF pressure in subarachnoid space means intracranial pressure, ICP. Hydrocephalus leads to increase in ICP and also ventricular volume in patients with communicating and non-communicating hydrocephalus. But in patients with normal pressure hydrocephalus, NPH, we have an increase in ventricular volume without any significant increases in ICP. We have some non-surgical treatment, but the main treatment for hydrocephalus is shunt and with shunt placement using a catheter. We drain excess CSF, and in LP we put a needle between L3 and L4 or L2 and L3 to drain excess CSF, and in ETV we can create a new opening in the third ventricle. In addition to clinical signs and symptoms, medical history, and medical images, there are also other parameters that may be useful for neurosurgeon to diagnose hydrocephalus, to evaluate the treatment outcomes of hydrocephalus. Intracranial pressure is one of these parameters. Because in patients with communicating hydrocephalus, non-communicating hydrocephalus, or IIH, we can see a significant increase in ICP level. But its measurement method is invasive. Today, we want to talk about non-invasive measurement of ICP. We don't need to drilling the skull. We don't need to, there is no risk of infection or any other problems like these. And hydrocephalus is similar to blowing into a balloon. When we are blowing into a balloon, we are increasing the pressure. It is similar to elevated ICP caused by hydrocephalus. Consequently, we can see balloon expansion. It is similar to increasing CSF volume. But in normal pressure hydrocephalus, there is no increase in pressure, no elevated ICP, but we have increase in CSF volume. Why? Because of compliance. Compliance is a parameter that can consider CSF volume and ICP, both of them at the same time. But its measurement method is also invasive. And today we also want to talk about non-invasive measurement of intracranial compliance, because this can be a better parameter because it includes ICP and CSF volume, both of them. In addition, we want to talk about non-invasive calculation of CSF stroke volume. CSF volume that moves through aqueduct of Sylvius in a cardiac cycle. In addition to our method, there is also other non-invasive measurement method to measure CSF stroke volume. dynamic MRI, cinephase contrast MRI, transcranial Doppler, they also can measure it non-invasively, and brain stiffness as a representative of the brain material properties, because some papers believe hydrocephalus means changes in CSF dynamics. Today, we want to talk about the role of the brain in hydrocephalus. And brain stiffness is a good representative to evaluate the condition of the brain before shunt surgery, after shunt surgery. And in addition to our method, MRE, elastography is also able to measure brain stiffness, but there is a little bit comments and problems about its measurement results, but eventually there are the parameters that we want to talk about. First, we have to talk about the brain model. From viscoelastic theory point of view, brain includes two components, brain tissue and fluid. The role of brain tissue is creating the deformation, volume change. And the role of fluid is dissipating the input pressure, because all elevated ICP caused by hydrocephalus will not convert to volume change. A part of these will be dissipated because of the fluid, and the rest of these will convert to volume change. And the name of brain tissue is elastic component, and the name of fluid is viscose component. For example, when we have an elevated ICP caused by hydrocephalus, we can see deformation in brain, but in brain tissue, elastic component, but fluid will act with delay because this is a time-dependent component of the brain. And after shunt surgery, after removing elevated ICP, the brain tissue return, but fluid will also act with delay. First, we have to define the mathematical model of the brain. In last slide, we talked about the brain model, but that was a simplified model. The actual brain model is a little bit more complicated. And in addition to elastic and viscose component, there is another component, porous component. So in total, we have three components to define the brain model. I don't want to get into the details of the equations, but you can find some more information in our recent paper about it. And the model of the CSF includes three different equations. First one is suitable to define CSF production in ventricles. CSF production is subarachnoid space that we consider is zero, but we know recent papers believe we have production and absorption of CSF in ventricular system and subarachnoid space, both of them. But this was our assumption. And after producing CSF, you have to create a movement because it should flow, you know. And this equation, Navier-Stokes equation, is able to create the CSF movement. The input parameter to solve this equation is velocity v, and the outlet will be ICV. We talked about this more in next slides. So to start simulation, we need two input data. One of them is a static MRI. We will use it to create 3D models of head substructures. And the second input data is cine MRI, is the result of cine MRI, because CSF velocity in anterior boards is the input data to solve this equation. So using cine MRI, we measure CSF velocity in anterior boards as an input to solve the equations. How can we create 3D model of head substructures? First, we have to provide head T-weighted MRI, and we imported the diaphragm extension of this file to mimic software. Then using image process, using segmentation and image reconstruction process, we provided point cloud of the ventricular system and other head substructures. And then we moved it to SolidWorks software to create the 3D model. 3D model of the head substructures is a representative of the anatomy, because in different patients, we have different CSF volume, brain volume, and any other different anatomy of these patients. And second, input data was CSF velocity and anterior and forward. This is something like this. Because of the heartbeat, we have a pulsatile flow, pulsatile CSF velocity. In this case, we have to provide a couple of images in a cardiac cycle, and first we have to collect all of them to show a brief video about the CSF movement. But to draw this graph, first software should track the location of one specific CSF particle in two images. For example, this red circle is a CSF particle. Because of CSF flow, this location will change in the second image. Software will measure distance between these two locations as a numerator of this fraction and time elapsed between providing these two images as the denominator of this fraction. The result of this fraction is the first point here. And when we repeat these procedures between second and third image, the result of this fraction will be the second point, and we are able to draw this graph. This is our second input data to start simulation. It is not a time-consuming process, less than 4.5 minutes. We are able to measure it. The name of our method is fluid-solid interaction. Fluid means CSF, solid means brain in our world. And as I said, our first input data was 3D models of substructures. It is a 3D model of one healthy subject. And the second data was the CSF velocity, which was measured using cine MRI. So as I said, this velocity was the input data to solve this equation, and the output of this equation is ICP. From 2000 to 2005, we have 4 papers. They reported the result of this equation as ICP, but there was a significant difference between this calculated ICP and measured ICP using ICP monitoring. Why? Because they couldn't consider the effect of the brain in the equation. This was just the equations relevant to the CSF. From 2009, little by little, some researchers tried to consider the effect of the brain. And they considered this calculated ICP as input data for solve this equation, and the outlet of this was velocity. And they considered that velocity as input data for CSF equation again, and after this repetition, they reported ICP. This is our result for a healthy subject, and you can see the ICP and CSF velocity graph, but this result, this calculated ICP had a still significant difference with measured ICP using ICP monitoring. In 2021, we published a paper and we optimized these parameters to calculate ICP with an error less than 4.4%. What was our main difference compared to other studies? CSF velocity in anterior cohorts, for the first time, we considered an in vivo data as input to solve this equation. Second one was S. S means CSF, the production of CSF in correct plexus. This is approximately 0.35 milliliter per minute, but this behavior should be pulsatile because of the heartbeat. And the main novelty was related to the brain model. We consider porous, viscous, and elastic, all components of the brain for the first time. And after considering all of these changes, eventually we calculated ICP with an error less than 4.4%. We repeated all of these procedures for 14 hydrocephalus patients before shunt surgery and in 9 stages after shunting. And we also repeat these procedures for 16 healthy subjects. From the beginning, we have 49 patients, and a couple of them has shunt surgeries had improved outcome, but only 14 patients had improved outcome without any changes in valve performance level over 18 months after shunt surgery, because we wanted to evaluate the natural interaction between blood, brain, and CSF without changes in the valve performance level. For data validation, we measured CSF velocity in aqueduct of Sylvius using cine MRI, and we compared That measured CSF velocity, these are calculated CSF velocity. The difference was less than 3.2%. And we measured ICP, calculated ICP in 11 patients before shunt surgery with experimental ICP, which was measured using ICP monitoring. The difference was less than 4.4%. 4.4% is not significant. For example, when we have a patient with 25 centimeters of water, 4.4% means 1 centimeter, you know? Maybe it depends on our error during the simulation. Maybe this was the error related to experimental measurement. Eventually, this error was not considerable. Our results show this is the result of ICP, average of ICP in our patient, healthy subjects, hydrocephalus patient before shunt surgery, and over an extended period of time after shunt surgery. And the corresponding curve for brain volume change and also CSF volume. You can see we had significant reduction in ICP and CSF volume level, and we had a 16.9% increase in brain volume. Another result was about creep. You know, we have many papers about morphometric analysis of hydrocephalus patient, but there are many contradictions and conflicts about their results. Some papers believe, for example, Haven index, it is one of the famous morphometric parameter to study hydrocephalic condition. So we have many papers which were published in JNS, and they believe Event index is a very good parameter to study hydrocephalic condition, but we also have many papers that they rejected this. So we considered another parameter, creep. Creep means changes in volume over time. This means, for example, now brain volume is 10, after 2 weeks it is 6. The difference between 10 and 6 is 4 divided by time, 2 weeks, you know. This was the parameter that we worked on, and the results showed in brain, we had a significant reduction in this parameter. And based on these results, right now, we have an ongoing project in MHFP about using creep as an indicator to study hydrocephalic condition based on AI analysis using machine learning and deep learning. Another parameter is residual deformation. We can consider brain as a sponge, and when we push this sponge, it is similar to creating elevated ICP caused by hydrocephalus. And when we remove our hand, it is similar to removing elevated ICP using shunt surgery. The results showed the differences even after 18 months, the differences between volume of the brain compared to healthy subject was 0.69. It is a normalized, you know, it doesn't have unit. It is a normalized residual deformation because the brain volume cannot return totally to the healthy condition, to the healthy brain volume. And compliance is another parameter. In a short period of time, the behavior of the compliance is an exponential function, but over an extended period of time after shunt surgery, this behavior was pulsatile, but eventually, after shunt surgery, we had a considerable increase in ICP level. Another parameter is stroke volume. The stroke volume, you can see the CSF flow diagram, the differences between these areas in diastolic and systolic means stroke volume. The results show there is a significant difference between healthy subject and hydrocephalus patient. And after treatment, 18 months after treatment, this value is so close to healthy subject. For example, in patient with an impairment in CSF absorption mechanism, we can calculate this parameter in some places in supraocular space near to sagittal sinus to study. It can reflect the problem related to absorption mechanism. This result is related to we calculated this result in aqueduct of Sylvius. Another parameter is CSF pulsatility. Pulsatility is another parameter, and Vomer-3 number is an engineering parameter that can reflect the pulsatility. The results show we had increase in hydrocephalus patient in pulsatility of the CSF flow, but after treatment, there was not a considerable changes in pulsatility of the CSF. And brain, we can see the maximum value of brain stiffness was 1 month after shunt surgery, and there was a significant reduction to 2 months. But after 2 months, the changes in brain material properties was not considerable. This means at least less than 2 months, the brain also playing a role. But sometimes we have hydrocephalus patient after a couple of days after shunt, after a couple of weeks, we can see signs, symptoms, and pain are returning, but everything about shunt is correct. Maybe everything is not CSF dynamic change, because if we have any elevated ICP or any excess CSF, this can be drained using the valve, because the valve is open after shunt surgery. Maybe the brain is also playing a role. Maybe some of these problems is related to the reaction of the brain and not necessarily changes in ICP level. And finally, unlike monitoring of ICP, monitoring of ICC compliance is not considered as a standard component of the medical care. This means, for example, when I say ICP is 32 centimeters of water, everybody knows it's not in the normal range. But when I say compliance is 2 milliliter per centimeters of water, we don't know if it is in the normal range or not. But conceptually, compliance is a better parameter because it includes ICP and CSF volume, both of them, but we don't use this practically. Why? In these papers, we talked about some reasons, but the result of our recent meta-analysis paper showed one of the most important reasons is related to the current measurement methods. Because, for example, if you want to measure compliance using intracranial bolus injection or CSF or lumbar CSF infusion, the result is not necessarily the same. And sometimes the result has a significant difference. But in computer simulation, we don't have this problem because we are working this equation, and the solution of an equation is a unique value. So maybe using development of our work in future study, we can provide a guideline to define the threshold level of compliance for healthy subjects, for hydrocephalus patient after shunt surgery with improved outcome, unimproved outcome, because we believe it can be a better parameter specifically to study NPH patients that we don't have significant changes in ICP level, and ICP doesn't work to study this patient. I'd like to thank Margaret Hackett Family Program as a founder of all of our projects, papers, and Professor Bakiamini, Professor David Fram, and my other colleagues, and thank you very much for your attention.
Say, very nice. Thank you very much. I had a question on one of those equations that square root was off, but we'll talk about that later. But you know, I think when we talk about this at other times, I could see, you know, people, not that I'm a Star Trek fan, but I remember Star Trek where they would take this thing and they'd go like this and they'd be able to analyze the whole body. But I feel like just like you measure temperature with a gun, sooner or later, using these kind of equations and things and these kind of studies, we should be able to non-invasively measure ICP or, you know, compliance or whatever it is, just by some kind of scan of the brain without having need for any invasive technique. And I think that this eventually is what it will go to, but that's my comment. Any questions that people have for these kind of studies?
There was an idea in the past that the pressure, particularly infants, bone expand into it, even though it is closed, a very small amount expands. And the idea was about doing research based on the expansion, take the pressure, which could be a very simple thing in the ICU.
Yeah, it's a really
Is that plausible? Something is still going on or not? Because that's why the patient's hydrocephalus, they expand. But even though it is closed supposedly in engineering, even though maybe 10 millimeter, you could calculate expansion and then measure the pressure. Is that something familiar to you?
Yeah, thank you very much for this question. First, I have to say one note. All of our results can be valuable for adult hydrocephalus, for communicating hydrocephalus. Maybe in pediatric, the story is different. But you know, in pediatric, we don't have this problem, but generally, their equations, you know, based on the equations, there are two independent parameters, volume, deformation, and pressure. At least from mathematical point of view, we cannot predict pressure based on volume or vice versa. For example, in NPH, we don't have any considerable changes in ICP level, but we have expansion in ventricular system. So this can be a really good idea to work in future studies, specifically about pediatric, because in pediatric we don't have NPH, maybe we can find. But there are some papers who try to find something about ICP, non-invasively. For example, we have some papers, they find correlation between diameter of optic nerve sheaths and changes in ICP level. Always it doesn't work, but it can be maybe in an emergency condition, we can say something based on diameter of optic nerve sheaths. Or some papers, we have some papers that they provided EEG, you know, and after signal process and classification, eventually they found some correlation between some of the features like frequency of EEG and changes in ICP. Or recently we have a couple of papers, they designed a tool, you know, they fastened this tool around the head, and in this area, they measured the deformation, you know, the deformation of head, and they found the correlation between this deformation and ICP level. But we are talking about measurement. We want to say what is the exact value of ICP, because always those methods that I described to you, always they are not working, and the basis of them is correlation. This means, but we know sometimes we have hydrocephalus patient is increased in ICP, but the eye, for example, maybe there is not any problem about the eye, like papilla edema or something like this, and the diameter of optic nerve sheath maybe doesn't have a significant changes. So taken together, I believe this can be a really good idea for future work, but our main intention is the value, you know, because when we have two hydrocephalus patients, maybe in one of them, ICP is 25, another one is 32, you know, there is a difference from when you want to make decision about them, there is a difference, but other methods just can talk about the correlation, general trend, not exact value, but this is a really good idea for future work. Thank you.
Really, really fascinating work. Thank you. You touched on a really important point, which is that, my understanding is correct, is that all of the data you're presenting here are exclusively to adult patients. And so, you know, based on your knowledge of your equations, do you think it's possible to incorporate modifications to the equations to account for growth of the brain and development that would apply to pediatric patients? Because as we know, for instance, you know, when you put a shunt in a child, the risks, you know, complications, revisions is much higher than if you put a shunt in adults, presumably because of growth mechanism. So do you think it's possible to modify those equations for pediatric patients in the future? And if so, what kind of data would you need to obtain in order to be able to make those modifications?
Thank you very much for this question, because in pediatric hydrocephalus, we have a large deformation. From mathematical point of view, solving this equation is a little bit different compared to adult that we have deformation, but the outer layer of, in all of our simulation process, the outer layer of subarachnoid space was considered a rigid body for adult. But in pediatric, we have a significant change. Yes, we can consider, but, oh, sorry. Let me see. Yeah, here we have a boundary condition. Specifically, we talked about the interaction between brain and outer layer of ventricular system. We consider this deformation and also deformation between CSF in subarachnoid space. This means inner layer of the subarachnoid space and outer layer of the brain. In pediatric, we have to consider another layer, you know, because we have a big deformation in outer layer, in the skull, in subdura, and somewhere like this. Yeah, we have to add a new layer, and it will be a little bit time consuming, you know, because time is also important, you know. We optimize everything to calculate all of them less than 3 days, you know, because for example, let me show you something. We worked with a supercomputer with 512 parallel CPUs and infinite RAMs, you know, and it works nonstop for 70 hours to calculate this. Because first we have to define a lot of small elements, and we have to solve all of this equation for one small element. Then we expanded with the whole anatomy. So it is a little bit time consuming. We can add another layer, but we have to use a better supercomputer. Maybe includes more than 1,000 CPUs, because time is important.
In other words, clinically, it's not so relevant.
But 2 or 3, excuse me, last note. Current non-invasive measurement method for compliance needs more than 3 days. We have a couple of papers, they need 1 week, because they inject additional fluid. Injecting is very simple. Over 10 minutes you can, but absorption of this is very time consuming. Re-injection is time consuming. Our method, the time in our method is right now is less than the current invasive methods.
Very nice.
Thank you. And as a layman, I've got a question based on our experience with Margaret. She's got 3 different shunts, 1 fourth ventricle and then 2 in her spinal cord. And as I understand, there really hasn't been a lot of advancement in shunting systems in decades. And that could be, you know, that could be an area of opportunity, if you will, for those patients that do have shunting systems that could be more responsive to changes in pressure, or it could be more effective in normalizing, if you will, the pressure. Is there any work in process on that? I know that at one point in time, Dr. Frum had mentioned that he had talked about it, but do you see any advancement or potential for advancement there?
Thank you very much for this good question. It's a really good question, because our main point is when you want to focus on shunt, this means everything is CSF flow, and we want to adjust it using shunt valve performance level and something like this. It is a really great idea, and many people's worked on this. But your question is really meaningful. Over this decade, we had many progress. We have many shunt with many different and variable equipment, additional equipment. But we believe I'm not a clinician, you know, a clinician should answer your question. But our primary idea is brain is also important. Shunt cannot be useful for brain. When we have a hydrocephalus patient, this means his brain was under elevated ICP over a couple of months. But after shunt surgery, we want to remove elevated ICP immediately to remove signs, symptoms, pain. It does make sense. But brain needs time. Brain cannot adapt itself with immediate reduction of CSF after shunt surgery. Brain, this is a relaxation time of the brain. It needs time to be adapted with this new loading condition little by little. So maybe gradual reduction of the ICP after shunt surgery can work better than changing the mechanism, and maybe not, because as I said, I'm not a clinician. There are many medical considerations to implement this idea, because gradual reduction means pain will be reduced little by little. Maybe the patient cannot tolerate. Anyway, I think your question was really important, because maybe everything is not shunt, everything is not CSF dynamic change, because beside all of this progress about the shunt mechanism, maybe the output was not enough. Maybe working on brain gradual reduction or something like this. This is a longer story, and a clinician can be answered. Thank you very much.
Very nice. Is there anybody who has any comments on something other than shunt? You shunt.
Well, just yeah, I've done some basic research on shunt valve technology, and I've got a friend in Seattle and another friend who is a consultant for Medtronic, and they think this is really the thing that's the innovation that someone needs to come up with. It's sort of a miniaturized valve that can measure the pressure, can adjust the resistance, and so that you can have better treatment, less shunt problems, things like that. So I'm hopeful, but I think it's the miniaturization. The technology isn't quite there yet, but my hope is sometime soon.
And actually be able to read the pressure and ensure that you're at the right place, because it's dynamic.
Yeah. Yeah.
So, great.
All right, very nice. Well, I'm sure everyone's hungry. It's lunch. Okay. I think we're gonna get started again. Everybody. Okay. Welcome back. Lunch, I think, was pretty good. Really, I mean, at these events, you don't often get lunch that was that tasty. It was really good. It was good. Well, thanks for coming back. So we had our morning session, and now really wanted to highlight the consortium and everything that David did to bring this together. And unfortunately, not all the consortium members could be here, but 3 of them are, and I think each person is going to kind of highlight what's going on in their program. And if you have questions about it or advice or anything like that, I think we all appreciate that. And we'll start with Dr. Baird. She's associate professor at Harvard and co-director of the brain tumor program there. Really, I mean, brain tumors is her real specialty, and that's something we haven't really talked much about, but it is a CNS, I suppose, in many instances, a congenital anomaly in some ways, and without further ado.
Yeah. Well, it's really an honor to be here after several years of working with the consortium. As Dr. Yamini mentioned earlier, it took a long time to get everything really set up so that it was working well and we could start collecting data. And we're now just I think hitting our stride. We're collecting a lot of data, so it's going to be fun today to talk about some of the projects that have started and are off and going. So, as Dr. Yamini mentioned, I do mainly specialize in brain tumors, but I do take care of a lot of kids with developmental disorders as well. And this is a little bit of an intersection between that with congenital neoplasms. Congenital neoplasms are really their own category of brain tumors. They're very different than the other brain tumors we see. They're extremely rare. The tumors are very unique, even with the same diagnoses. They're very unique when they're found in young infants, and they're very poorly described. So I think it fits well with some of the goals of using these multi-institutional consortiums to gather data for this very uncommon thing. Just a little bit about congenital brain tumors. There really is no clear definition for what this means. There's hardly any literature about them. And what is there? People have different definitions. So some will describe congenital brain tumors as only tumors that are found on prenatal imaging. Some that they're found in the first 3 months of life, some in the first year of life during infancy, and others that they are diagnosed in the first 3 years of life. They're so rare, and there is such little data on them that when you find these incidence quotes, they're all over the place. So I just picked one. They have an incidence of 0.34 per million live births. I have no idea if that's true or how they would have come up with that number. How little is out there about them. And as I mentioned, they're very poorly studied, they're very poorly understood. And they have a wide range of behaviors and outcomes, which makes them extremely challenging to treat. There have been pretty minimal efforts to improve survival in this patient population and improve our treatment options for them. And this is our most vulnerable population of patients, these young infants. So you can imagine that the kind of treatments we use for brain tumors are very difficult with this patient population. And we really do need novel therapies, like to treat these more efficaciously and to minimize side effects. Most of what's out there in the literature are case reports. There are very small series that are range from 2 patients to about 12 patients. There's some signs that they are increasing in frequency. That may just be due to improved imaging with the prenatal screening. So we're capturing them. And they are a great diversity of heterogeneous behavior. We really need larger numbers than we've had than 12 patients to truly understand anything about them. And some of our therapies are really just not options at all, given these young developmental stages. For instance, we cannot use radiation with them, just with no membranes. I mean, it's not an option. And there are many chemotherapeutic agents that are just not an option.
It's a little bit of a lag on them.
So I'm going to talk about just a few cases as an example as I go through this. One of the challenging when you have a patient with these tumors is that there's no standard for treatment. And a lot of these tumors are just big gnarly tumors. This is an example of a patient who has a little tiny tumor. And you can see this little mass right there. That's where it is. A lot of times when we find tumors in these patients, we don't know how they're going to behave. We don't always know what they are, and we have to extrapolate their treatment from similar tumors in other anatomic locations or at other ages. So this was a child who, when he was 6 weeks old, started having seizures. On an MRI, we found this little dot there, and it slowly started to grow. And at first we thought maybe it's a hypothalamic hamartoma, not a neoplasm, but then it did grow. And he was doing okay, but I didn't want, with it growing, I didn't want to lose the opportunity to take this out for a minimally invasive endoscopic approach. So we took it out when it was small. And no one knew what it was. It was shown around to many, many neuropathologists. They gave it a descriptive diagnosis and had some atypical features, and we have no idea what to do with it. So we just watched. So it's just an example of finding something and just really not knowing what to do with it. Some mixed-ordered spindle cell version of something. Another challenge is how variable the prognosis is, even with a diagnosis that we do know. So they don't always behave in infants as they do in older children and adults. It's the glioblastoma in a 3-month-old. I think there are a lot of places where they just wouldn't treat this. Glioblastoma doesn't know fatal tumors, and terribly in adults. They do terribly in older children. So we can't radiate them, which is our standard of care. And so a lot of people would just go to palliative care. But the ironic thing about congenital glioblastomas is that even though they look exactly the same in the microscope, they do not behave anything like adult tumors. This is a patient where we took the tumor out. We've done nothing since. And he is 3 years old now, clean scan. And we would never see that in an adult. So they can have an identical appearance histopathologically, but they are completely different biologically. We find different biologic drivers in these tumors. Many of the congenital GBMs have ALK fusions, some have ROS1 fusions. We have targets for inhibition for them that we don't have in other glioblastomas. And then there are a couple of case reports out there of not treating these and they spontaneously regress. This is another tumor. This is diagnosed when this patient was 1 day old. A high-grade glioma with an ALK fusion. And we took this tumor out, watched it for a few months, had a small recurrence, took that out and put her on an inhibitor, one of the tyrosine kinase inhibitors that you mentioned earlier. And she's doing great. She's 2 years old. And this is a case that, I think it's totally understandable not to know what to do with it. A lot of places have treated her, and I think she's going to do okay. So it's one of the other challenges with these tumors is that when we do know what they are and we do know how to treat them, our treatment options can lead to really significant neurocognitive and psychomotor impairment. This is, Joyce and I were just talking about ATRT. This is the two-mental ATRT. And we took this tumor out. The patient did great, looked like a normal baby for a few months. And then they start their chemotherapy. They basically live in the hospital the first year of their life. And they slowly start falling further and further behind neurodevelopment. And the tumor comes back. They get seizures. We did early radiation for this patient. And this patient only survived 2 years. And it was a nightmare for 2 years. And this is a patient I may argue, if we had known what was going to happen down the road, we probably would have recommended not to do anything. Strain it puts on the families, both socially and employment-wise and financially, it's really significant. And here's another tumor, cortical carcinoma, also a very bad tumor that gets really harsh chemotherapy for adjuvant treatment. Took this tumor out, the chemotherapy cycle, was in the hospital the first year of his life, and had some issues with populated hydrocephalus that the doctor did a bunch of surgeries. And he is now a normal 5-year-old. You would never know. He puts it on his plates. His development is normal. So it's all over his mouth. It's just really hard to know what these kids are going to do. Here's another patient that's particularly challenging. This patient was diagnosed prenatally with this supercellular mass and ended up being a craniopharyngioma, which we suspected. And of course, the big risk here is endocrinopathy. So this patient was born at 31 weeks gestation. And so operating on a premature infant and giving them endocrinopathies, including diabetes insipidus, is basically a death sentence. I mean, it was so hard to manage a child with volume requirements that has no vasopressor function. So I really struggled with what to do with this case. And I watched it for a while. So that middle picture is after about 6 weeks, it was getting bigger. And the child started to neglect their right side. And so I knew that they were starting to lose their vision. And so I took her back and I just poured out the tumor. And as you can see, just left the capsule there, left all the hormone function alone. And that's where we're at now, just kind of waiting. And it will come back. And this is going to be a very, very challenging tumor for me to manage. As we all know, dealing with endocrinopathies, especially in children, requires a lot of effort on the part of parents. They really have to be engaged and involved in monitoring. And this family has very limited capacity to do that. So we're doing some social issues there too. So very unique challenges for these tumors. So some of the questions we have for this project: why do these tumors develop during fetal and young infant stages? Can we identify any risk factors? Can we identify any maternal or infant exposures? There's a couple of case reports, including one published by Dr. Davenport about in vitro fertilization of genital tumors. So is there going to be any association there? Are there any associated developmental anomalies? There probably are. That's been suggested in what's been published so far. And can we identify the patients who have the potential for a really excellent treatment response and long-term survival and acceptable treatment toxicities? I think there are serious ethical considerations to exposing these young children with our therapies, and we can figure out a pattern and a better way to address that. That would be great. Can we clarify discrepant outcomes with similar diagnoses? And can we ultimately get some insight into the epidemiologic differences that may lead to more appropriate treatment decisions and hopefully improve their survival? So our goal is to create a high volume database of congenital CNS tumors with our consortium institutions, gain some insight into the epidemiology, look for associated factors, and then look at treatment survival outcomes and neurodevelopmental outcomes. And we so far have 203 patients and counting. A few more, which is far, far more than has ever been published. So I'm really excited about that, and we will hope to get some good data on this project. And we've completed the chart reviews and are just starting some of the data. Future projects that we talked about that can maybe be prospective, can collect some circulating data from these patients, and we start looking into genomic information, and hopefully can create some clinical care guidelines that would really help the providers and care for these patients. So really want to thank the Margaret Hackett Family Program for supporting this. I just think it's going to be very important work for these patients, and especially the research assistants who have spent a lot of hours in the chart reviews putting together this patient cohort, and of course our patients. Another example of a patient. This patient was born, had a healthy mother, healthy father, healthy pregnancy, born with the most severe proptosis I've ever seen. Couldn't close his eyes, could barely get his lids over half of the nose, has a skull base just riddled with these, what ended up being neurofibrosis. That's spontaneous and very, very difficult to treat. We ended up decompressing the orbits very aggressively to try and save the vision, and she was this was great. About 2 years out now, so hopefully getting better at managing some of these diseases. So I'm going to move on to talk about one of Dr. Sayama's projects, and then questions about it.
Yeah, so comment and questions at the same time. So this is great. I like to say that every time Lisa starts presenting, my heart drops because I'm like, what nightmare am I going to see next? Because I always call her about my nightmares. But interesting, because you mentioned something that's very, very important. As neurosurgeons, we live and die by what did the preoperative imaging show and what did the postoperative imaging show? And is everything gone? And we were trained and grew up on, is everything gone? And if it's not gone, let's go get more. And that was in an era where we didn't understand the pathophysiology and the genetics of it, and there weren't other options, and drugs weren't available. And it's really changing our culture and pediatricians' culture and the oncologist culture to really think about this. What is our goal? What are we going to achieve, and at what cost? So I applaud you on bringing that up. That's a really, really interesting thing. And where do you think we now stand on using cDNA and getting samples so that we have a biopsy before we have a biopsy to help us make that decision? Yeah.
I think we're not there yet. I mean, we actually have a project going at our institution that's very preliminary with infants, and I know with infants at least. But I'm hopeful we'll get there. Now, there has been a little bit more work done with DMGs, at a bunch of places, and So far, I have found that it's not, it's helpful when it's positive, but when it's negative, it's hard to know what's true. So it's not there yet, but I think that we will.
Yeah, I think it's a great project. Are you collecting, molecular data? Because now more and more, tumors are routinely being sent to Foundation One or CARES and so forth. Different gene alterations.
We're definitely collecting.
Yeah, and I think
So
that's.
we don't have it on everyone's thing, we have it really over the last 10 years of patients.
Yeah.
But I think most of our institutions continue to do it now.
Yeah.
So we have more of these.
I think it's a great study because not only is it a huge number and multi-institutional, but to have that, molecular data is really important. I think probably find some really interesting things.
What was the length of survival in glioblastoma that you had?
The longest one right now is 3 years.
Glioblastoma.
I mean, they're both still alive. And they're, of my patients, one is 3 years out and one is 2 years out. And then there are reports in the literature of long-term survival, 5-10 years.
They could live longer than adults.
20 years ago.
Yeah, like the tumors go away.
Or don't recur after resection.
Or those few cases of spontaneous regression. It is bizarre. And there is something very biologically different about that.
And also partly because the head expands and they don't go through as much intracranial pressure that
Right.
maybe adults go.
Which is why they probably survive the fetal stages with these massive tumors, because the head is expanded. And I will say, I didn't show the, I have seen congenital glioblastomas that died very quickly. Or that were neurologically devastated at the time of birth. So I'm showing the positive cases here because they're so surprising, but it's not all patients, not all congenital GBMs are stories.
I'm curious, if it's a very small tumor, how do you know how some of these cases are coming up? And you wouldn't normally be doing that kind of diagnosis or anything like that. How do you, what's the percentage? Obviously, it's large, but
So fetal screening, maternal ultrasounds, test some of these macrocranial seizures. I think a lot of these babies are born premature, and so they get ultrasounds to confirm age. And I think the vast majority are not. And then if we find them in later months, the head starts to grow too big, which is why we include longer lengths of time, because they probably were tumors when they presented at 2 years of age. It just took that long to manifest. But I think the ones we find really in the first few weeks of life are that select. That's really good. Some other.
One comment that you may have already been addressing about samples for future analysis sort of thing. The benefit of having the tumor and then peripheral blood to be able to compare to look for changes that happened in the tumor is really important. But I can say that if you have a little bit of investment early on in actually sequencing the whole genome of the tumor tissue or the peripheral, you can hang on to that data forever. And you don't necessarily have to have more peripheral blood samples or more tumor sample. It just depends on what your resources are when you have it. So like learning from experience, the further you can go with the genomic analysis, the better off you are, because you'll always have the data. Even if you don't know the genes today, you don't know where they stop and start, you don't know what they mean. The sequence is the key work. So it's a little investment early on, but worth it in the end.
I think I'm fortunate because we have resources to do that. We do that for every tumor. I think a lot of places, they can send it to the NIH to get validation, and it's free right now. And so I hope a lot of places are doing that for at least their tumors. And hopefully it can do that as extensive.
most of the services in most places don't have full exome sequencing for tumors. They're really focusing on the 500, like the UCSF 500 gene panel, and this. And it's most of them are not full. As it becomes cheaper, it's going to be everyone's going to be.
Yeah, some of these commercial, foundation notes, there's a whole bunch right now.
Cheaper and cheaper, and it's good research.
It's
You
great
know, you can
research.
get,
I mean, we
they're
collect so
called
much data,
Exo
we
One
don't
grants.
use that. What they actually do.
We will move on. Very nice. Ben, Ben's going to present Dr. Sam's work at OHSU. So another one of our consortium members is Northern Health Science.
Okay, so this is a project from Dr. Tina Sayama, who's not here today, and I'm not sure if is she on, Jesse? You're on. So these are her slides, and hopefully I do right by her. But I can say that she's the division head of pediatric neurosurgery at OHSU. She's also a former partner of mine, is a phenomenal surgeon, wonderful person, a really compassionate physician. It's great to have her. So she is also we have a lot of spine interests. She's also a specialist. And was interested in scoliosis as it relates to tethered spinal cord. So there is a known association with tethered spinal cord and scoliosis. A third of patients associate with that. Her literature review showed some prior studies that suggest that if this is detected early on at younger ages before they go through a lot of their main growth spurts, and those kids can be untethered, their curves don't progress as much, and they possibly can avoid some of these bigger surgeries when they're older. A lot of the previous studies, however, looked at multiple etiologies of tethering, including some of these more complex forms of spinal dysraphism, like meningocoel, lipomyelomeningocoel, and the others. And she specifically wanted to look at simple tethered cord and how it relates to idiopathic scoliosis. Simple tethered cord is when there is a tight, fibrous, thickened, or fibrolipomatous fatty filum terminale, and there is either a low-lying conus or some suggestion that there is tethering of the spinal cord without or abnormal. Most patients with tethered cord present with bowel or bladder dysfunctions. There are a myriad of other symptoms, musculoskeletal symptoms, pain, and scoliosis is one of them. But if you just look at the tethered cord, simple tethered cord population, most of them present with bowel bladder symptoms. And patients with idiopathic scoliosis alone do not tend to have bowel bladder symptoms. So I think it makes for a good hypothesis that those are a patient population that we should be able to screen, capture, and screen. So patients with both idiopathic scoliosis and simple tethered cord represent a unique tethered spinal cord, as they do not tend to present with bowel bladder dysfunction. So that was the hypothesis for putting together this project. So with the goal of describing the clinical characteristics of both scoliosis and the simple tethered cord population, identifying clinical factors that might aid in early identification, and optimizing our potential to treat them early on and avoid future scoliosis surgeries. So as Rich was mentioning, doing these single center studies it's really limited. It's limited by the small number of patient population and all the different factors that go into that. For instance, tethered spinal cord in the field of pediatric neurosurgery is quite controversial and is managed very differently at different institutions. Patients are screened at different rates, and a patient who has an identical scan and identical clinical picture can be treated completely differently. So doing a multi-institution study here, I think, was very important. She looked at the patients at OHSU in Warbecker and had a population of 26 patients that she has analyzed separately, and then brought this project to the consortium, adding the 5 participating institutions. And I was just asking Jesse, we now have 127, is that what you just told me? Patients? 109.
We're in the subgroup with the idiopathic.
With the subgroup of idiopathic. So it's going to be a much more powerful number for data analysis. So doing a retrospective review of looking at these patients, looking at their clinical presentation, their demographics. This is some of the early data that she's looked at and found that pain was the most common presenting symptom in the smaller cohort. But then when she looked at all the institutional data with the larger cohort, it showed that the most common presenting symptoms were actually sensory complaints. The possible takeaways here: patients with idiopathic scoliosis may have atypical presenting symptoms of pelvic spinal cord, making it easy to miss this diagnosis. Pain is not a standard indicator for MRI imaging for a lot of pediatrics or spine surgeons. And probably neurosurgeons, but neurosurgeons tend to be a little bit more prone to pain than MRI. And so frequently it's missed. Not with an MRI to identify this. Back and leg pain or tingling paresthesias is one factor that really with this cohort seems to be something that should trigger an MRI. And then about half the patients in the OHSU cohort ultimately required fusion because they were referred to.
Thanks, Melissa. This is a topic near and dear to my heart, so it's very exciting to see this. I would just add that this is a really important topic because we've looked at this, at least preliminarily, through the PSSG, and a lot of times the kids would present with scoliosis, at early onset scoliosis, and they'll get an MRI, we'll show it to the spinal cord, and they'll follow it. So we looked at that category of patients. And what we found is that every year that they get older, the chances for the scoliosis progressing 10 degrees increase by about a third. So the earlier you can detether them, the less the likelihood that there's scoliosis. It's a small cohort, so that having the numbers is really going to be helpful. But the big message is that the kids should get an early MRI because early intervention is better. And a lot of times the orthopedic surgeons in the past wouldn't do it because they're like, well, we're not going to get MRI unless we're going to intervene, meaning casting, bracing, surgery. The message we're trying to get out to them is you see a kid with scoliosis, get an MRI. And they already do that for anybody with congenital scoliosis and congenital anomalies and stuff like that. It's this is going to be great.
That's very true. Even at our institution where it's very easy to get an MRI, they get referred when they got an MRI because they were progressing on more rapidly than expected. Their curve was atypical, their pain was atypical. And it's always that scenario when they might be not diagnosis of scoliosis, get the MRI.
It's important because saying, I talk to different orthopedic surgeons who do differently, but pain and tingling is an early sign, and you should image scoliosis. Is not supposed to be painful. Scoliosis.
The other thing to note is that tender cord release is a very minor, easy, low risk procedure to do. It's not like we're talking about doing some big major invasive intervention. It's a really easy procedure. Much bigger issue.
Last slide, the urinary. 2 slides back there. Maybe 3 slides back. There we go. Yeah. So there were a significant number that had bladder dysfunction.
Yeah, and then the smaller cohort, less than this cohort.
Yeah. So the tended cord study is probably the furthest along. I think that has analyzed much of the data, and that's for the consortium. That's the study that would probably be the first one that really have all consortium members contributing, and after that, this is a general brain tumor study. So now we're going to have David Bauer speak to us. Work that is just beginning version, again, by our constraints and everything that he's going to look at it. It's his children. Dr. Bauer, Associate Professor Baylor, and pediatric neurosurgeon there. And Texas children. His clinical interest is clearly pediatric spine surgery. And he's going to talk to us about work there.
Well, yeah. 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 Yeah.
Well, thanks everyone. I want to thank the Hackett. I've really enjoyed being part of this consortium, and really appreciate Dave Frim bringing me in, and now working with Moyes and everyone else. It's really just it's been a lot of fun, and in part because I do practice guidelines for national neurosurgery, and I think that there's a need for guidelines and how to take care of patients with rare problems. The problem is you can't make guidelines if you don't have data, and so really this is all about finding that data through the consortium. And so I have no disclosures. And sorry, I don't know how to. Jesse, do you know how to move the bar? Or if not, that's okay. And basically, thinking about congenital pediatric spine problems, which is thank you. Thanks so much. I don't think it's progressive. It's not progressing now. So sorry. We've really heard quite a bit about. Thank you so much. About how rare these are, and thinking about the genetics behind it, having gosh, 800 plus different problems, and this being rare, so 1 in 2,500 to 1 in 500,000 or more live births. Really, there's not a robust clinical experience that anyone has, and there's a lack of published clinical evidence. We've talked about the problems with single center case series over decades, in part because in that case series, the surgeon or the team may have learned things over time, and so what they're doing at 20 years isn't what was happening at the very beginning, and so it's hard to gain sort of insight. You might know about sort of the natural history, but you're not going to know clinical tips and pearls through a study like that. There's an unknown natural history or behavior of many of these problems. It's rare to have a coordinated long-term follow-up study. It's unknown or poorly documented all of the potential comorbidities that you may have to consider. And kids are living longer with many of these conditions, and so there are new problems that may arise over time that are unexpected. And so some of the things that I see and that I plan to study are hemivertebrae, so congenital fusion of the vertebrae. You can see where part of the vertebrae is formed, parts not formed, and so over time that may or may not cause scoliosis. You can see many kids with congenital hemivertebrae might have heart problems, and you can see the child has had a sternotomy, and so patients with achondroplasia and other skeletal dysplasias, you can see overgrowth of the foramen magnum with spinal cord compression. or kids with rare storage diseases, mucopolysaccharidosis, where you can see the spinal stenosis, the vertebrae that are formed differently. You can see the scoliosis and spinal cord compression. This is a child that went from ambulatory to non-ambulatory, and then at age 15 needed a really extensive surgery for scoliosis, some decompressions, but now is ambulatory again and doing well. This plastic craniocervical junction, you can see sort of the abnormal configuration, and a lot of these problems, ventral compression, so dynamic instability, were shown in earlier talks today. And so these are things that I see routinely. I specialize in pediatric spine, and I would love to have great long-term data and follow-up on all of these rare problems. But I think we need to know a couple of things, not just kids that are operated and not just sort of operative techniques, but what's the denominator. So when we think about the rarity of these problems and also the multiple conditions that could be associated with them, if we can combine aggregate patient data from centers, the operative data, also the non-operative data, I think we could really make some important observations. And so my overall goal for my study is to create a guide for patient management and treatment. And I really would like to know if someone has a certain diagnosis, what's the chance that this patient is going to need spine surgery? What type of spine surgery? What other problems do we need to worry about? And a little bit like the genetics aspect. And so, you know, thinking ahead, what are the things I need to worry about? But then what is the schedule of follow-up studies? Should a patient need an MRI every year looking for a problem? Maybe things don't start to happen until you're a teenager and you hit puberty. Maybe we don't need to do a yearly MRI. Maybe we start MRIs at a certain age. The nice thing in modern medicine with electronic medical records is that we have ICD-10 codes. And so these are more specific codes to say that a patient has a certain diagnosis. And so we have ICD-10 codes for even rare problems like morchio. And so with the use of Epic or our medical record system in multiple hospitals, I have a plan to look at the different codes, abstract the chart, and create a database. This is a consortium database. The plan is to really look not just at patients who are operated, but patients who are not operated. And so how many patients with morchios have surgery? When do they have surgery? What types of surgery? Were the surgery successful? Thinking about the patients that are at high risk for spine fusion, many of these kids have skeletal dysplasias. And so then is one center able to better take care of these patients? Are the complications lower? Are they more successful with surgery? And then basically create manuscripts, presentations, but finally a guideline or sort of management recommendations. And I think in the end, having a not necessarily a cookbook, but sort of a comprehensive source for the management of kids with difficult spine problems would be very helpful for clinicians. So this is still in the planning phases, and so I have no data. But I was sort of happy that Dr. Anderson sort of stole my thunder and also truly talking about the need for this, because if everyone thinks there's a need for this, then I think it would be well received nationally. And really, it's just pooling the numbers and all of our centers see many kids with these rare problems. So I wish I had more, but I hope to have more to come in future meetings. And so again, thank you for having me.
Well, David, you have a lot of data, you just haven't extracted it yet.
That's right. That's right.
Any comments about or this study? Clearly, it's at the beginning stages, but it's an important part and it may actually end up having the most patients included in this diagnosis.
Yeah, I think Jesse, how many patients have you identified? Great. Yeah. So I think this will really have something.
Just a quick question on your data, in your data. I noticed that Morkio had 3 different ICD-10 codes and none of the others had more than one. Why? Do you know why that is, or but is it gonna throw off?
So there are different subtypes.
There's A and B, 2 different enzymes, and they kind of phenotypically overlap, so it shouldn't matter, but it's a problem with a lot of the lysosomal storage diseases, and sometimes they're called that.
Yeah.
And then sometimes they're called by the enzyme, sometimes by the name of it, so you have to cross all possible things.
So the ICD-10 code should take care of all of those, or
Technically, it should.
yeah.
And I don't, I
New
can
ones are
add one
created.
comment. I don't want to be negative about any part of this, but we're all, we're trapped by Epic. We all use Epic. It's very much dependent on someone putting the diagnosis in. So you're very attentive to what is the diagnosis this person has. Not everybody feels that same way. They want to address their hearing issues, so they put hearing deficit, and really they have Morkio.
Yeah.
But if somebody hasn't put it in there, unfortunately, we'll never find them. So it's only as good as what the data are going in. We've done a lot of these searches like this looking for people. I'm not saying not to do it because you'll find a bunch, but
I think that we found a bunch, which is great. So I think it depends on the institution. So if an institution has someone, a geneticist who seen patients early and then put in the correct code, then it's in the problem list. And so I think that's the key part. But they're very granular. I mean, it's really something else that that we have that, whereas it's not just like general polysaccharidosis, it's very specific. So I think that will be helpful because it may be very different. I mean, the thing is, lumping all skeletal dysplasias into one box, you're going to sort of get an average, but you're not going to, some patients might do well, some patients might not. And so I think the subtypes might matter. So more to come. Hopefully within a year. I mean, if we have all this data, it shouldn't take too long to abstract the chart. So.
And our last social member, Moise Daniel, Cedar Sinai, the head of pediatric neurosurgery, Cedar Sinai, professor of neurosurgery there. So I'm going to talk to us about a study that he is very interested in, MRI, flow, toothpaste, and I'll let you.
Okay. I'll figure it out during the talk. So share screen.
That's so many ones.
Great. Yeah, that'd be great. Perfect. Fantastic. There we go. Thank you everyone for sticking it out this long for the last and least important talk note. This is going to be really fun. Moise Danielpour, the lone pediatric neurosurgeon at a 1,000-bed adult hospital. And now we have Garrett Children's. So this is the newest endeavor at Cedars. The Vera, my chair, who endowed my chair, after much prodding towards both the hospital and her, we got a $100 million donation to create a Garrett Children's Hospital at Cedars-Sinai. That is going to be a lovely next stage, really developing all of that. So today I'm going to talk about something that's really interesting. Get this to work. There we go. Oh, no conflicts to report, except that I also get money from the Garrett Foundation to do all of this work. So I don't know if that's considered a conflict or not, since I'm giving a talk here. American Cancer Society, National and the NIH grants, and both the Smith Family Foundation and the Garrett Family as well. So today I'm going to be talking about true fist imaging. It's a specific MR imaging that really developed from doing cardiac MRIs where the heart is moving and there's blood flowing through it. And this provides a high contrast MR imaging with cardiac gating, so it accounts for the heart beating. It provides excellent spatial and temporal resolution over time. And what I mean by that is that the brain pulsates and spinal fluid flows. So what you see out in MR imaging routinely is an average of signal over time. So small objects and things that move get completely averaged out. So what you see on an MRI is not what really happens. And for some things it may be fine, a disc is not going to be pulsating as much, and that's okay for spine surgery, but things that we do in congenital disease and that frequently involve hydrocephalus and movement of fluids, you really need something that's an MRI movie over time. And this is much more better suited to look at fine structures and congenital anomalies in the CNS that can be different from each kid. So that small differences is very important. So what do I mean by that? So here's a really interesting case. Here's a kid who had a preoperative MRI, came to me from, I think actually from Las Vegas. Big serinohydromyelia, weird kind of a Chiari with this obex dilated like that. And not really narrow, not necessarily abnormal posterior fossa. So we postulate that this was truly an arachnoid veil. We went inside, and that's what we found. And we fenestrated the arachnoid veil when we did our decompression over here. And then postoperatively, you see over here, the kid still had serinohydromyelia. And headaches as well. So to me, it was like, okay, did this close off? What's really going on? Why is this kid having these headaches? And the syrinx is still there. So we did this true fist imaging. You can see there is flow there, really nice flow. So it is still open. And I wouldn't have necessarily known that based on this imaging. What was really interesting, do you see the floor of the third ventricle pulsating up and down like that? And despite the fact that previous literature looking at this would suggest otherwise, would say, oh, that's normal. To me, that was that there is a difference in pulsatile pressure between the subarachnoid space after exiting from here and the ventricular system. So we went in and did a third ventriculostomy, and this stopped happening where it's pulsating up and down crazy like that, and all our headaches disappeared and our syrinx continued to improve after the surgery. So this got me thinking about things that we do. Here's another case that's really interesting. Here's a kid with a posterior fossa arachnoid cyst, and when we got this true fist imaging, this is all pulsating up and down. It doesn't look like there's any CSF going through here. And we did a decompression. Indeed, it was an isolated arachnoid cyst, and we opened this up, and the tonsil actually went back up again and stopped pulsating as badly. And this kid's symptoms, which were really odd, this kid had club foot. And after the surgery, the club foot improved, went away. And before doing the surgery, I sort of told the parents, I'm doing this, but I don't believe it's going to work. This club foot has nothing to do with this. I was wrong. Here's another really interesting kid. This kid presented intraventricular hemorrhage of prematurity, presented late, came to Cedars. This is all this material here, dilated ventricles, dilated fourth ventricle. Okay, we're going to put a shunt in this kid. This kid's got communicating hydrocephalus for intraventricular hemorrhage of prematurity. And I put a shunt in, and fourth ventricle is gigantic still, right? So there is truly aqueductal, but it's an isolated fourth ventricle, or is it really? Or is this the results of having a big dilated fourth, and even though I put a shunt in, you don't really need to do anything about this? So then we did proof of study. Really interesting. CSF is not outflowing. The arachnoid is bulging out. This is truly isolated. And went back in, and everything was really scarred in over here. And this is a long, long video, so I'm not going to show you that. What I'm going to show you is, this is sort of what it looked like after I opened up all the arachnoid adhesions at the skull base on this kid. And now look at that. Really interesting. You see how much more pulsatile this is? And here, after the decompression, that's gone away. And over time, the cerebellum did expand out. This did get smaller, and the kid did improve. So this type of imaging is helpful because you can really see flow. You can see small structures, you see movement. You can make some inferences if you understand the pathophysiology to some degree. And so as part of the consortium, we started thinking, well, what if we looked at endoscopic third ventriculostomies, right? Endoscopic ETVs is a technique to treat non-communicating hydrocephalus. Indications include aqueductal stenosis, arachnoid or choroid plexus cysts and tumors. And it's been used with a lower success rate in other conditions, including post-hemorrhagic hydrocephalus and meningoceles. The features that are favorable for success: older kid, discovery later than 6 months of age, no radiation, meningitis, et cetera. A lot of radiological features as well, thinning of the third ventricle, et cetera. You guys all know this, not going to go through it. And the ETV success score is very interesting because when you're talking to parents and you're saying, okay, your kid is less than 6 months of age, therefore, based on these criteria, you have a 30 or 40% success rate. They go, oh, how do I know my kid is one of those 30 or 40%? So I'm just going to take your word for it. We're going to try it. If it doesn't work, it doesn't work, right? So when is the risk of earlier ETP justified? The risk is small, but it's significant if it happens. Basilar injury can be a death sentence. Can you have additional functional information, such as the pressure wave that we're just talking about, without invasive monitoring that can help make the surgical decisions and what we do? And then after we do the procedure, in the absence of immediate changes in the ventricles, can we gain functional information and chances of success based on postoperative imaging where we know, okay, this is not a kid I have to follow up really closely because everything looks really good, or gosh, I need to see this person, the chances of this failing are very, very high. So can we include functional information? And I want to give credit to the person who really got me thinking about pulsatility about 15, 18 years ago when Jack came to visit us, Jack Walker, who's now retired, just for some of the younger folks who may not know who Jack Walker is. And he gave this great talk about using cyanuric acid in animals in the lab, and where you put in the basal cisterns a tiny amount, all the mice get hydrocephalus. If you put it over the convexities and you put 3 times as much, only 30% get hydrocephalus, and even then it's like 4 months out. And the idea was that if you're inducing scarring of the basal cisterns, you're increasing the pulsatility that occurs and a difference in pulsatility and high pulse pressure. And that is very, very important when we do ETV. So it really started me thinking about this. And I thought, gosh, it would be really good if pulsatility gives us information where we know who to make those decisions on and who to operate, and afterwards know who's going to be a success or not. So MR imaging, quantification of movement of the lamina terminalis. This has been done mostly in adults, and mean diameter of the optic recess and the greatest change in diameter being in one volunteer that they did this was 1.5 millimeters, and it's not a huge number of patients that they did this. So in normal adult patients, there's not a lot of movement that happens if things are normal. So we did this preliminary study. We said, okay, let's just grab a couple before my darn system works and I can grab all the patients we've done this for and see if there's anything to it. So interestingly, and I'm going to go through this because the data is incomplete because we didn't get preoperative CSF flow on every patient. There was no need. Why would you do that? So one patient, which we did in that lamina terminalis after we did an ETV, the fluctuations went down dramatically. The kid then failed. It was a young kid. It closed over. We did the true fist again, and that's what we saw. Parents did not want to try another ETV. They just wanted a shunt in, so we put a shunt in. This kid, we didn't have a postoperative MRI scan. That's why there's no line to it, to remind me of that. But a follow-up study showed that the ETV had closed. This family also did not, and the pulsatility had gone up compared to the prior preoperative study. Initially, the kid did well, following along, closed, and when we looked at the pulsatility, there was much higher pulsatility, suggesting that there's not a good passing of pressure waves between the subarachnoid space and the ventricles. And this kid family did not want ETV again and put a VP shunt. Here's two kids where it was successful. Pulsatility went down on two separate studies. Pulsatility went down, and they never required a shunt, and they've done well with ETV. So that's really interesting. Has anyone? I'm not that smart. Has anyone else thought of doing this? Yeah, they did, and they did it in adults, which is why our former colleague here was talking about this, the dinner that we had before. I kind of asked them, are all your studies in kids or are they in adults? It's really interesting. They did this looking at the movement of lamina terminalis, and then after ETV, and they noticed that there was a restoration of movement of the lamina terminalis. In all the patients that we're looking at, the lamina terminalis, when they had aqueductal stenosis, was not moving. It was big and dilated and not moving. And after they did the ETV, it started to move, which is just the opposite of what we were finding. But interesting, age 16 to 39. And all of these were delayed, not young kids with congenital aqueductal stenosis who were immediately symptomatic. And so they may have compensated hydrocephalus. So here's the thing where what we're doing with kids is very, very different. And we need to understand how it works in kids. A growing head, a lot of other factors. And I want to show you an example of this, which made it even more interesting and got me a little bit more excited about doing this. Here's a kid that was watched as part of an ETV trial where they're kind of watching and saying, okay, the kid's not getting worse, and we're going to keep going and see how old this kid gets, so there's more chance of success of the ETV. And the mom is actually a physical therapist at that said institution, children's institution, and their kid was just not doing well, was not meeting milestones. You know, yeah, it wasn't getting worse, but wasn't meeting milestones. So I don't know, you know, so we kind of felt very differently that, you know, we even got another, even though there were changes in the ventricular size, and then there was we got another and continued increase in ventricle size, and said, look, you know, this kid's not doing well, not really reaching milestones, ventricles are getting bigger. And so we did an ETV on the kid. The kid came to us with a big bulging fontanelle. And after surgery, the fontanelle was soft and sunken. It was really interesting. But here's the preoperative study. Now, this kid had an open fontanelle. There's not a lot of movement in that lamina terminalis, even with the presence of aqueductal stenosis. Post-op, with an open fontanelle, after I've done a third ventriculostomy and I see the fontanelle sunken, still not much movement in the lamina terminalis. The kid's ETV closed. A little bit later, like a year out, the fontanelle was still open, but much smaller. You see how the lamina terminalis is pulsating more compared to these? That's why I kept them going, so you can just keep going back and forth and looking at it. And even after I went back and opened it back up, and then the fontanelle was sunken again, had gone to more full, and then sunken again, and the kid's doing phenomenally well, the fontanelle is still open. So there isn't this huge pulsatility that we were seeing before. And this kid's doing absolutely great, and is now like catching up with milestones and starting to walk and doing quite well. So the interesting thing about this is it's really complex with kids. It's not so simple. And you got to look at a lot of different factors. We were just talking about, you know, hydrocephalus and skeletal dysplasia and the venous system, and is it obstructive? Is it communicating? And I think this is a technology that will give us a lot of information about pulsatility, and it's not just pressure, especially when you have an open fontanelle in kids and at age groups that you're doing it, preoperatively and postoperatively. It's going to be a matter of really having post, long-term outcomes, and then try to understand what this data will give us about pulsatility in terms of decision-making, in terms of improving who we select to do third ventriculostomies on, and who we know has failed and for what reason, especially in kids who may have a combination of communicating and obstructive hydrocephalus, such as the kids with interventricular hemorrhage prematurity. So I only really talked about aqueductal stenosis, but I've been collecting all this information on our Chiari patients, as you saw some of those interesting ones, and now on skeletal dysplasia patients, kids with achondroplasia. And some of those achondroplasia patients who progress even late do really, really well, and then later on in life start having headaches. The ventricles are not necessarily changing. Some of them have papilledema. Going in, using the TrueFisp, and then doing the third ventriculostomy, and they improve where they shouldn't. They don't have foramen magnum stenosis. And it's even on kids who have operated on decompressive foramen magnum. And then they have papilledema, they have headaches. We do a third ventriculostomy, and we're improving the communication between the ventricles and the subarachnoid space, and their headaches, symptoms, papilledema goes away. So I want to thank the Hacketts for really trusting in us. You know, I know the process is difficult, leaving a couple of people who get together and say, we're just going to collect data and we'll come up with some interesting stuff as a result of this. You can't always predict what you're going to find. You think you're going to go in one direction, and then everything is different than what you imagine. It just doesn't always make sense with kids. And I also want to thank my friend David Frem, who I've known since I was a resident. He was an attendee here at U of Chicago just starting out, who really believed, and we had this discussion again and again every year at the ASPN. And then someday he said, you know, we're going to do this, and got everyone together. And it was kind of funny because he said, well, I got all of Dr. Scott's fellows and ones since I trained at UCSF. Thank you.
Okay, very nice. Can we just hold questions for a few minutes, and then we can ask them, only because I think some people have cars at 2:30. I don't want you to be late, and we'll get to that in 1 second. I just want to move on to quickly while we have time. One of the things that you know, we had fantastic speakers talking about their work, and the consortium is doing a great deal of work and retrospective analyses, and hopefully sooner or later maybe prospective. But one of the things that we talked about with the program is, you know, bolstering science and getting new minds involved in the program, and the things involving congenital CNS anomalies. And we thought one of the best ways to do that is to have a grant system, offer a grant for people to apply for funding, funded by the program. And we put a call out that this is the first year we're doing that, and we had it in the University of Chicago, and it was very successful in the applications, and probably thinking that in the future we would open it up to the entire consortium. But we had applications, and I had 3 people review the grants completely in an unbiased way under significant rigorous rules of kind of how we evaluate NIH grants. And from that, we came up with 2 people who we would like to fund to do work based on the Hackett program. And I wanted to recognize those people today, and maybe have them come up here in the short period of time that we have. And maybe we'll, I gotta read what the projects are. So, I try not to do any reading, but I gotta read this project. Dr. Taylor's project is, I think I kind of understand this. It's he's gonna do work with I won't name the molecule, but it's a channel, a potassium channel, and part of the potassium channel is made into a protein, and one end of the protein is this new transcription factor, and he's going to be studying that behaviorally in mice. physiologically and mechanistically. And the panel thought that this was a fantastic project. And please come up here. And, postdoc here at the University of Chicago, and he's going to do this over the next year. We discussed it extensively at the project yesterday, and we're really happy to have you do this. So next year we'll be hoping to get an update on how things are going.
There you
All
go.
right.
And Dr. Beatty, next year we'll have, you can report on the results of the research issue.
Yeah, we'll have you give us a little presentation about
There you
how
go.
things are.
I read it and I have no idea what it is. So it's gotta be good.
And the second one, Dr. Yang.
On my own though.
Yeah, this is a molecule, I know a little bit less about this. SNAP-GAP1, the mutation is called autism and epilepsy and other things, that he's going to be looking at targeting that with exercise on the leaflet that plan. He's going to come up here. Congratulations. Again, the same thing. We'll hope to hear from you next year. Congratulations and all the best. He's also a postdoc here at the university in department in genetics or genetics, human genetics. Yeah. So thank you very much. These projects are very, very basic research, and the one project is associated with Timothy's disease, which is even rarer than rare. So work that comes from these things, just like everything else, like I mentioned before, could make substantial difference. And I think it's really important work. And the same with Dr. Wang. Patients who suffer from these kind of diseases with autism and other congenital CNS anomalies are very important, and again, relatively rare in some ways. But just with that, I wanted to say thank you. That kind of brings this to an end. I know the cars are going to be here at 2:30, and I don't want to have you guys delayed getting to the airport. The highway is crazy now with construction, and I don't want you delayed at all. But thank you very much for coming, for the speakers. It was really nice. The guest speakers, all the consortium members. I mean, just coming from all over the country, basically, the different coasts and the South Coast. You want to look at that as well. And it's really been a pleasure to host this. And the Hackett family, Margaret, thank you very much. All the people who were affected by your contribution to this. They very much appreciate it.
You're welcome.
Yeah. I didn't mention, and I will, those awards are named after David Frim. That will be another lasting legacy. I mean, he has everything here at the University of Chicago. It's a very long lasting legacy. And unfortunately, he couldn't be here, but those awards are named after him. Everything that you see here really is, it was his brainchild. It's in his honor. And we wish that he could be here to celebrate it with us and to hear everything. He will give reports about what's going on. And definitely miss it. So, thank you very much, and safe travels. Oh yeah. We get some photos, please.
Really different, yeah.
All right.